Do vaccines cause PMR? This is a really important question because PMR, or polymyalgia rheumatica, is a disease that affects older people who often get vaccines. And some people say, I got PMR after I got fill in the blank vaccine. And so, is it a trigger? Is it just a coincidence? What do we know so far? So, I'm Dr. Megan, the Prednisone Pharmacist, and I'm here to help people with PMR because so many of you are stuck on prednisone. So I wanted to answer this question many of you have asked. I wanted to review the latest evidence with two reports, one of them going over an entire country's results and another one that shows 3 case reports of specific individuals who took a vaccine and then got PMR. So what is PMR? PMR is an inflammatory condition where there's often pain in the shoulders, an inability to lift a hand to your face or strap a bra or get restful sleep at night and roll over on your own. Things like that are really hard to do when your shoulder is not working properly. And so you end up taking prednisone for a long time. And you want to know what caused this. Why am I was previously healthy and now I'm totally debilitated and unable to take care of myself. I can't even get out of bed on my own, right? That's a question many are asking. So when we had the opportunity for millions of people to get vaccines all at once, we can study the incidence of what happens after that vaccination. So in 2021, when the COVID vaccines were given millions and billions of times, they were able to track this data. And it wasn't the first time that vaccines have been possibly linked to PMR. And I'll go through some other vaccines that have case reports in the past as well. So is it really a vaccine-specific effect, or is it just a coincidence? Let's look into the research. So Jarrett, or maybe Jarreau, I'm not sure how to pronounce French words, but he did a survey of the country of France and the vaccines given there and what the incidence of PMR, GCA, and other complications were. They looked at over 70 million doses given to adults aged 50 and older in France. And that's an important distinction because PMR can only be diagnosed if you're 50 or older. It's not going to be PMR or meet the guidelines for PMR if you're less than 50 years old. And of those 70 million doses, they found 179 cases of PMR and 54 cases of giant cell arteritis, which is GCA, a related inflammatory disorder. And those were all diagnosed within 1 month after vaccination. So how many is that per million? The reporting rate for PMR was 7.1 cases per 1 million vaccinated individuals. And for GCA, it was 2.1 cases of GCA per 1 million vaccinated individuals. What's tricky is when you compare this incidence of getting PMR or GCA with the incidence that normally occurs with no trigger that's being identified. It's 112 per 100,000 individuals 50 and older. So I want you to notice there's a 0 difference there. 112 out of 100,000 get it naturally without any vaccine trigger, compared to 7 per 1 million. That's 10 times more people. So this is their statement. Considering the relative risk of both PMR and GCA per adult and the injected dose, we observe a lower incidence of these diseases following COVID-19 vaccination compared to the non-vaccinated population. This finding poses challenges in interpreting pharmacovigilance studies. So that's what this is, a pharmacovigilance study. So it's really tricky because your chance of getting it in general are much higher than what it's showing your chance of getting it from the vaccine from that study is. So let me share those case reports of individuals and the pattern that we identify from them. So Irani and colleagues in 2024 published 3 case reports. These were all new onset diagnoses of polymyalgia rheumatica following the Pfizer BioNTech vaccine for COVID-19. All 3 patients developed PMR symptoms within 1 to 14 days after their second dose of the vaccine. All cases responded well to prednisone or methotrexate therapy and were able to put their disease into full treatment and no longer experiencing symptoms of PMR. And the timing definitely suggests a link, but is it just a coincidence? Is it a trigger? Or is it just an unfortunate timing coincidence? Well, what about other vaccines? For the influenza vaccine, one review found 28 reports of PMR or GCA following the flu vaccine, and most of those cases occurred within 3 months of vaccination. That's an incredibly low incidence compared to the general likelihood of getting PMR. What about the zoster vaccine to prevent herpes zoster reactivation in the form of shingles? One study found a higher rate of GCA in individuals who received the zoster vaccine compared to those who didn't. It showed 75 per 100,000 for those who got the vaccine compared to 41 cases per 100,000 for those who didn't get the vaccine. What about hepatitis B and tetanus vaccines? Isolated cases of PMR have been identified after treatment with those vaccines, but the rates are so low that definitive risk is impossible to calculate. It's a tricky situation no matter what, because nobody wants to get these infectious diseases. Nobody wants to get the flu and die of the flu, as you're more likely to do if you're an older person who could be getting PMR. Nobody wants to get shingles. If you've ever talked to someone who has active shingles, it's horrific. The skin is so painful, you feel like you can't even wear a shirt or put a sheet over your body. Like you just want to run around naked, or not even run. You don't want to do anything. You're just in such incredible pain. Just touch is painful. And then tetanus is fatal if untreated. So it's a very tricky situation because these vaccines save lives and prevent terrible complications. But are they a trigger for PMR or GCA? So those case reports showed after the second dose of the COVID-19 vaccine by Pfizer, it happened to 3 people that they suddenly got PMR. So that does show a temporal association. That means the timing makes sense. This suggests a possible immune response as a trigger for PMR, especially if you're genetically predisposed to this anyway. If you have Northern European ancestor, like Sweden, Denmark, the United Kingdom, places like that, like me, you have an increased risk. So there's the immune response hypothesis. This is what it says. Vaccines trigger immune activation to protect against infections. In rare cases, this immune response might overreact in some individuals, leading to inflammatory conditions like PMR. And then potentially some ingredients in the vaccines that aren't the active ingredient may also be causing an immune response, or other factors might be at play. Maybe it was truly coincidental. Maybe there were other infections or viruses that were actually happening in the body at the time and the person didn't even know about it. So should you be concerned about vaccines causing PMR? Here's some reassurance. PMR is incredibly rare after vaccination. Just 7 cases in 1 million individuals who would be likely to get PMR at a likelihood of 112 out of 100,000 individuals. If you were to extrapolate that to a million, that means 1,120 per million individuals versus 7 caused by the vaccine. 1,000 in normal situations versus 7 by the vaccine. It's a dramatically smaller number. And the other thing to consider is vaccines do save lives. I know that's a really politically sensitive situation, and a lot of people feel really strongly about this, but statistically speaking, vaccines save lives. Billions more people live on this earth today because they are not dying of smallpox and measles, mumps, rubella, tetanus, and so many other infectious diseases that truly do save lives. And the potential risk for triggering PMR is infinitesimally small compared to the risk of those conditions. Like your chance of getting the flu and dying of the flu is much higher than your chance of getting PMR from a flu vaccine. While PMR is a very miserable condition, it is not life-threatening. It makes life a lot harder, and I never want to make it sound like I don't appreciate how terrible it is to be a person with PMR. But it's a treatable condition. You're not going to die of PMR, whereas you can die of the infectious diseases that vaccines prevent and treat. So in summary, while there's a small possibility the vaccines may trigger PMR, GCA, or other inflammatory conditions to appear for the first time or to reactivate an existing disease, the overall risk is very low. The evidence suggests that vaccination is not a major cause of PMR, and the benefits of vaccination in preventing severe illness far outweigh the risks. So if you have concerns about vaccines and PMR, be sure to talk to your doctor about your concerns. They can help you decide in your specific situation with your genetic predisposition what is the best choice, working with you closely in a shared decision-making situation. And if you want to know what I've learned all about PMR and how to treat it, I went to a Harvard Medical School seminar and learned all about the latest, greatest treatment options for PMR that did not exist 5 years ago. So check out that video now. PMR natural remedies. Are there any? Is there anything that can help that's natural with the symptoms of PMR or polymyalgia rheumatica? I'm Dr. Megan, the Prednisone Pharmacist. And this is a question that gets asked often because if you have PMR and you have to take prednisone, you're probably wondering, is there anything else I can possibly do besides prednisone, right? I'm a third-generation pharmacist. I'm board-certified doctor of pharmacy, and I personally had to take prednisone for my own autoimmune condition. So I understand what it's like to take prednisone, and I understand the desire to do anything but prednisone. So I want to give you some real feedback about what you might find on the internet and what is actually real based on science, and what isn't necessarily real, maybe based on hope. And I'm sharing this on the same week that a brand new study was just published. So I'm going to share that awesome study at the end of something that is actually science-backed and real. So make sure you stay to the end to find out exactly what has scientific evidence behind it. So let's talk about some things that may help, but maybe not. We don't really know. They haven't actually been studied in PMR specifically. So PMR, polymyalgia rheumatica, is an inflammatory condition. Maybe it has some autoimmune components to it, but essentially there's really terrible pain and inability to move and potentially fatigue. And the shoulders and the hips are the most affected joints. It cannot be PMR if the person is under 50, and it typically is in a person who is of European descent. So some things that may help with inflammation in general, not necessarily PMR inflammation, are omega-3 fatty acids. I especially enjoy omegas because my name is Megan and my husband will sing me a song, Omega Fatty Acid, to me. Anyway, so omegas are associated with decreased inflammation. Some ways you can get omega-3s include eating fatty fish like salmon, mackerel, and sardines. Other ways are to supplement. Since I live really far away from an ocean and fish is never fresh by the time it gets to me, I personally take Nordic Naturals omega-3s every day. If you want a link to how you can buy it, just click the link below. But I take this every day, not only because it's decreasing inflammation, hopefully keeping my autoimmune disease in remission, but omega-3s are also super helpful for brain health, decreasing your risk for dementia, for eye health, and just heart health. Overall, omega-3s are something I personally take every day. Along the lines of inflammation, there is some suggestion that an anti-inflammatory diet can help to keep your disease inflammation minimal. And there aren't any studies that I'm aware of specifically the diet and PMR. But in general, The idea behind an anti-inflammatory diet is minimizing processed foods, like cutting processed foods out of your diet altogether. No added sugars, basically things that come in a box. It's fresh fruits, vegetables, or even canned fruits and vegetables, and good cuts of meat from cows that have been grass-fed, from chickens that have also been exposed to sunlight. These animals have been treated humanely and in a good way, and so the quality of their meat is higher. Prioritizing vegetables and fruits, minimizing sugar. That is essentially the main backbone of an anti-inflammatory diet. And whether or not that's going to be a good remedy for PMR, it's a great strategy to minimize your prednisone side effects. So I advocate for that in general for anybody who has to take prednisone. And hopefully it can minimize the amount of prednisone you need. So because it's keeping your inflammation even a little more at bay. Other things that are kind of related are you could spice up that anti-inflammatory diet with herbs. Things like turmeric, ginger, garlic, but you also have to be careful because some of these can interact with your other drugs. For example, turmeric can interact with prednisone, leading to an increased risk for bleeding. So it's a tricky situation because these herbal remedies, these spices, these naturally occurring properties might feel safer than prednisone, but they have their own risks. And especially when you already have a disease and you're having to take medications for it, you have that added complication of herb disease interactions and then herb drug interactions. So you've got to be really careful, make sure that there's no interactions. All right, this one has a little bit more research supporting it. Low impact exercise has been shown to improve polymyalgia rheumatica symptoms. You might be thinking, oh, I have such terrible shoulder and joint and hip pain. I don't want to move. I just want to be on the couch. Well, they've shown that walking, cycling, swimming, these low impact activities can really help your body with PMR. They can reduce stiffness, improve your function, and improve your quality of life. Now, let's talk about stress management. PMR is a disease of inflammation, and taking prednisone affects your ability to deal with stress. So anything you can do to keep your stress minimal is great. Whether that is doing breathing techniques. I love the Headspace app or the Calm app to help me minimize my stress using meditation and breathing exercises, doing yoga, Tai Chi, and then cutting out other stressful things from your life if you can. If you can magically win $1 million and not have to worry about money, if you can be able to quit your job, whatever it is that is causing extra stress in your life, if you can do things to minimize that, that can possibly help improve your PMR quality of life. Next is magnesium. Magnesium is important in over 300 chemical reactions in your body, and many of those have to do with your muscles. And PMR has to do with the muscle joint capsule, and it's possible that there could be some added benefit of adding magnesium to your diet or as a supplement while on prednisone. So finally, I promised that I would share the one that actually has evidence that is breaking news published this week, and that is vitamin D. There is evidence showing that those who have PMR usually have low vitamin D, and that those who supplemented it into a safe range the fastest were the most likely to go into remission. And that study, it was kind of small, so, it's hard to say whether this is like a cure or what, but the association is there that when you can get your vitamin D up above 40 and even up into the 50 to 80 range, that is associated with a higher likelihood of going into PMR remission. So vitamin D supplementation, getting sunlight to make vitamin D, those are great natural remedies to help you with your PMR symptoms. And if you want to know a supplement designed specifically to help with the prednisone side effects that includes vitamin D and magnesium is Nutrinize Zone. You can get this at nutrinize.com or on Amazon. It's designed specifically to help you minimize your side effects and feel the best you possibly can while taking prednisone. Just go to nutrinice.com. It was developed by me. It's been tested by third-party labs and is exactly what the doctors who prescribe prednisone the most recommend, with calcium, vitamin D, magnesium, chromium, potassium, and many other ingredients to give you the support you need while on prednisone. Go to nutrinice.com and try it out today. Breaking news. This is hot off the scientific presses. PMR research has just been published that might change a lot of things. This might help answer the question of why some people with PMR are able to go into remission faster than other people. Researchers have uncovered a surprising factor that could make all the difference, and it's something you might not expect. So what is PMR? PMR stands for Polymyalgia rheumatica, and it's a condition that primarily affects people older than 50, usually in their 70s or 80s, who are of Caucasian European descent, where there's dramatic pain in the shoulder or hip area that comes on suddenly and pretty much only responds to prednisone. It causes stiffness, fatigue, aching in the shoulders, neck, and hip areas, making it impossible to drink a cup of water or for a woman to latch her own bra. And while prednisone is typically the go-to and sometimes only treatment for PMR, new research has uncovered a surprising factor that might predict remission. And it has nothing to do with steroids like prednisone. And that's saying something because I'm Dr. Megan, the Prednisone Pharmacist. I'm a board-certified doctor of pharmacy and third-generation pharmacist. So what did this study look at? Well, the researchers found 29 people with PMR who definitely did not have another disease that's really closely related called GCA, or giant cell arteritis, and had never taken something before. It didn't matter whether they had taken prednisone before, but there was something that they wanted to test for. They wanted to make sure that none of these people had ever been exposed to before. They followed these 29 PMR patients over 21 to 24 months, so around 2 years, and they checked for things like relapses. They tested their blood for the ESR, or erythrocyte sedimentation rate, and CRP, C-reactive protein, both signs of inflammation and the disease flaring. And then this is the thing they tested that nobody's really looked at before, and it was vitamin D levels. The 25-hydroxy vitamin D levels in the blood was the new thing that this study looked at. And then they compared all of these blood levels to normal people of the same age who had the same blood tests taken. So they were on average about 70 years old, both the PMR group and the otherwise healthy individuals, and they compared them. And one thing they noticed right off the bat was that the vitamin D levels in the blood in the normally healthy people was the same as in the people who have PMR. So it's a function of age that the typical person in their 70s usually has low vitamin D levels. Somewhere around 20 to 22 nanograms per mil was the normal level in both the normal and the PMR patients. So vitamin D wasn't a predictor of getting PMR. What they did next, though, is where the big difference comes in. So they decided to supplement vitamin D to get to a goal of more than 40 on their blood test. And they were starting out at around 20. So the goal was to basically double or even triple or quadruple that number. Being less than 100 and greater than 40 was essentially the goal. It's not safe to be above 100, but in this situation, their goal was to be above 40, to be kind of closer to the normal range of vitamin D for health. And so they took different forms of vitamin D, usually cholecalciferol, which is vitamin D3, and a few people did calcitriol. Some of them supplemented daily, some of them supplemented weekly, and a few supplemented monthly. No matter what, the goal was to get greater than 40 on the blood test. Check out this chart. The first line in blue shows the vitamin D levels. The next line in red shows the ESR, and below that is the CRP. These are both indicators of inflammation in the blood. you can see as the blue line goes up, that's the vitamin D level, that the inflammation is going down. Wow, what a cool correlation, showing that the blood level of vitamin D is really important to get the disease inflammation into remission. This next chart shows the clinical response at 3 months. On the left side, you see the change in the vitamin D levels, and on the bottom, you see whether a person has persistent disease or is in remission. And you can see a very all out red shows just a tiny change in vitamin D. All of those in green show a bigger change, with some even up to 22. That was the mean, was 22 nanograms per milliliter increase in vitamin D levels. And what does that really mean? In the next chart over, you can see the delta vitamin D in green is showing that you have a 3 times almost greater chance of going into remission, 2.89, if you have a change in vitamin D at 3 months compared to those other things that are prednisone. The study revealed that an increase in vitamin D levels after just 3 months of supplementation was the strongest independent predictor of remission, even when accounting for prednisone use. It was nearly a 3 times greater chance of being in remission. What's also interesting when it comes to the prednisone is what they said. The baseline prednisone intake were identified as significant independent factors negatively associated with the 25-hydroxyvitamin D serum concentrations. The amount of prednisone a person had taken before they started this study was a predictor for having low vitamin D. Could it be that the prednisone is causing the low vitamin D? Good question. And other studies have proven that prednisone causes low vitamin D. It's also causing low calcium and other nutrients. All of these low nutrients combine not just to worsen your chance for remission, worsen your disease, but also worsen your chance for side effects from the drug. Things like bone loss, broken bones, loss of height. I'm going to read this from another study. It said, a UK-based database study of 15,000 individuals reported fracture rates, that's broken bones, 63% and 67% higher for PMR and GCA respectively, with less than 13% of patients receiving bisphosphonates. That's a type of drug that prevents osteoporosis fractures. Another set of articles using the same data set looked at 5,000 people with GCA and demonstrated incidence rate of ratios of 2.4 for osteoporosis and 1.4 for fracture in GCA. So you have a 2.4 times greater risk for osteoporosis and 1 times greater risk for a broken bone if you have GCA. And they go on to conclude, a basic tenet of the management strategy when considering glucocorticoid-induced osteoporosis is that it is far easier to prevent bone loss in the first place than it is to rebuild it following such loss. So both this study I've been announcing that is so exciting and brand new, and this study talking about the risk for osteoporosis are concluding the same thing, that getting your vitamin D, calcium levels into a healthy range is more likely in this first study to get you into remission, and the second study to prevent osteoporosis. We'd rather prevent the osteoporosis than to have already suffered a loss and be unable to inch back up, because this bone loss is permanent. There is no getting it back. Optimizing your vitamin D levels was strongly associated with remission, which could support better management of PMR. This might even allow for less steroid therapy prescribed by your doctor. If your disease is in remission, it's under better control with less reactive proteins, the ESR and the CRP, you might need less prednisone. Vitamin D may lead to a less need for prednisone use. So what should you do? Step 1, get your vitamin D level checked. You can ask your doctor to prescribe it and have your insurance pay for it. Or if you'd rather rush and get the answer quickly, I have a vitamin D test available on my website. Second, start supplementation if needed. If you are up in the 50 to 70 range, maybe you don't need supplementation. But if you are not reaching the goal of this study, which was greater than 40, and you could see the trend of that blue line showed up to 80 was still safe and good, keeping people in remission, then supplementation may be good for you. But it's individualized, right? Like you need to be getting this tested and getting the right dose of the vitamin D for you and your level of inflammation, your skin type, your ability to make vitamin D from sunlight. All of the factors that are involved in vitamin D are unique to you specifically. So get tested once, start supplementation, and get tested again to make sure that you are reaching your goals, that you're rapidly getting there, and be in close communication with your doctor to achieve these goals. If you want a really easy way to start out is to get Neutronized Zone. This is designed with the calcium, vitamin D, and other nutrients that prednisone is stealing. Other nutrients that you need to support your bones, your metabolism, restful sleep, and keeping your inflammation under control. You can just get it at neutronize.com or click the link below. I invented it because I personally had to take prednisone and did not want to have to deal with my family history of osteoporosis. So I got a morning bottle and a bedtime bottle. You take 2 in the morning and 2 at night. And this supports restful sleep. This supports a good, strong metabolism. And it's 1 month supply, all you need to start out with for your basic vitamin D supplementation. If you need more vitamin D based on your blood test, then I've got other vitamin D that I can recommend. So just click the link and it'll take you to a bundle of all of the things that I recommend. The vitamin D test, Neutronized Zone, other vitamin D supplementation that you can go for, and maybe other things that I'll throw in as a bonus. So check this out. Click the link below to get my bundle for people with PMR who need support with vitamin D. How common is relapse or recurrence of PMR after starting prednisone treatment? I was asked this question or a variation of it many times in my survey of people taking prednisone for PMR, GCA, and other conditions. And I found a scientific article that helps answer this. Plus, I learned all about this at a Harvard Medical School seminar I recently attended with professors from Harvard and other elite medical institutions telling me all the things I needed to know about prednisone and PMR. So PMR stands for Polymyalgia rheumatica, and it's a condition where pain, stiffness, and inflammation, usually the shoulder joints, sometimes other joints like the hips, are affected, and it's very painful and debilitating. The problem is that the main treatment is prednisone. Amazing medication. I personally took it for 9 months. It saved my life, but it comes with a lot of side effects. And so some researchers did a study and published it in Clinical Rheumatology to show how often people were still taking prednisone after certain periods of time, and then helped hypothesize why this is happening. Steroids like prednisone have been the go-to for PMR and other inflammatory conditions since the 50s and 60s because it's so effective at relieving the pain quickly. Often people with PMR will be surprised at how quickly the pain relief happens when they take prednisone. For some people, one case report showed as little as 12 hours after her first dose, a woman received pain relief. And for many others, it's within a few days or at least within less than 2 weeks. It all depends on the dose, though. So sometimes you just don't have a high enough dose to get the pain relief. So they wanted to see how many patients were still taking prednisone for PMR after certain periods of time. And in this study, they found that after 1 year, 77% of patients were still taking prednisone. After 2 years, 51% of patients were still on prednisone. And even after 5 years, 25% of patients were still on prednisone. These numbers show that the guidelines that recommend tapering off after 1 year just aren't realistic for most people. It just doesn't happen. People are stuck on steroids for a long time. The guidelines recommend getting off of steroids within a year, but more than 3/4 of people are still stuck on them. It's just not fair to try to put that kind of pressure on someone to unrealistically expect you to be able to get off of prednisone within a year when statistically that's a lot less likely than possible. So why are patients stuck on steroids for so long? According to this study, one of the main reasons is relapses. The researchers found that about 43% of patients had a relapse within the first year of treatment. That means while you might have started out at somewhere between 25 and 15 milligrams of prednisone, and then you slowly taper off your prednisone, waiting to make sure your inflammation and pain is under control before you ever take your first drop in dose, and that it stays there. Despite that, 43% of people had a relapse. And relapses are common even after your symptoms had improved somewhere during your prednisone taper. And so that meant an increase in the prednisone dose, back up to wherever the last dose was that it worked for you. But relapses don't explain the whole thing because 77% of people were still on steroids, even though only 43% had a relapse. So other factors may include, first, incomplete remission. Some patients don't fully respond to steroids and need ongoing treatment. Second, the tapering. Some doctors may be trying to follow that guideline and tapering too quickly, and that might necessitate ongoing treatment. They obviously are trying to minimize your side effects to the steroids, but it's coming at the cost of the disease coming back. It's just such a tricky balance. And then third, when this study was completed, there were a lack of steroid-sparing options. That means there are a lack of alternative treatments that you could use for PMR. At the time of the study, there was nothing FDA approved for PMR. In fact, at the time of the study, prednisone wasn't even FDA approved for PMR, and still isn't. Isn't that funny? It's probably the condition that requires the most steroids over time, and it's not FDA approved. It's not listed on the label at all. So why would you even want to go on a steroid-sparing agent? Well, let's talk about the side effects that they found people actually experienced. 43% of PMR patients experienced severe side effects from taking prednisone, and over 31 months of treatment. The side effects included osteoporosis and fractures, which means breaking a bone, high blood pressure, diabetes, cataracts and glaucoma in your eyes, and finally infections. Most of those side effects cause long-term, irreversible, permanent damage that, unless precautions are taken to prevent it, or you have to do drastic measures like medications to treat it, or for cataracts, you have to actually have cataract surgery to remove it and replace it. So we've got to find better alternatives. They've looked at older drugs to see if they could help, and maybe methotrexate or leflunomide might be alternatives, but the data is pretty mixed and not that effective. But there's good news. Since this study was published, 2 drugs have been FDA approved for PMR. These drugs are Actemra, which is tocilizumab, and Kevzara. And both of these drugs are injectable biological medications that you have to get your insurance to pay for because they're very expensive. They work pretty well in about half of people, but the other half just doesn't really work for. So if you're one of those lucky half, then hopefully you can get access to these medications. Then you can slowly decrease off of prednisone to minimize these complications and side effects. So PMR is a very tough condition because prednisone and other treatments fail so often. The recurrence rate is real and dramatically high, and the side effects happen even at lower doses. And so you want to do whatever you can to get on the lowest effective dose for you, carefully listening to your body to prevent relapses and recurrence of the disease. And then be gentle with yourself, realizing that the guidelines are just not realistic, and it's totally normal to still be taking prednisone 2 years after diagnosis because more than half of people are. And so do what you can to minimize the side effects while taking prednisone. And I have a checklist of things that you can do to minimize all the side effects I mentioned, plus others. And it's called the Prednisone Checklist. You just click the link below to download it now. So the research shows that there have been 5 randomized controlled trials of methotrexate for PMR. and the results have been mixed. So let's see what we learned from these studies. First was the Ferraccioli study, and they found that patients taking methotrexate needed less prednisone overall compared to those who didn't, with 1.84 grams for methotrexate versus 3.2 grams for the prednisone placebo group. The second was the Caparoli study. This study showed more people in the methotrexate group were able to stop prednisone completely at 87.5%, compared to the placebo group at 53%. Those on methotrexate used less total amount of prednisone during the study. Next is the Nazarinia study. Similar to other studies, this one found that methotrexate helped lower the total amount of prednisone patients needed over 44 weeks. They did a follow-up study of the Caparoli study, and over 6 years, they basically found that it had no net benefit, that people were experiencing the same amount of prednisone side effects. And while they might have little less inflammation overall on their ESR blood tests, it didn't really translate into less complications from taking prednisone, less prednisone use, really. So while methotrexate may have potential as a steroid-sparing agent, the evidence remains uncertain because of the limitations of the studies. They were small studies. Maybe they were selecting for healthier people, or maybe some of the people in the studies they were actually treating had rheumatoid arthritis instead of PMR. So let's answer some of your questions about methotrexate and PMR. How effective is methotrexate for getting off prednisone? Like I just went through, the evidence shows that for some people it might be effective, but for many others, it may not really make much of a difference. At the Harvard Medical School seminar, this is what the professor said. He said, regarding methotrexate, one study 20 years ago, I think he meant Caparoli, showed methotrexate was quite successful. A newer study in 2022 showed that it was no better than placebo. That's what they said there. So according to that guy, he's no longer prescribing methotrexate for people with PMR when there are so many different other options we can choose from now. Next question. How should I taper methotrexate after stopping prednisone? Methotrexate tapering should only be done under the supervision of a doctor. They'll assess your inflammation levels in your blood, your relapse risk, and your overall health before adjusting the dose. They'll probably taper you gradually to avoid flares, but it's definitely not something that you should do on your own. So back to the question about, I'm hesitant to take methotrexate because of the terrible side effects. So what should you know about methotrexate? And another medical school professor at the seminar shared this. He said, I think the big hesitation with methotrexate comes in the fact that first, it was originally designed as a chemotherapy medication. And second, it has the letter X in it, methotrexate. And our human psyche associates an X with toxic or skull and crossbones or other poisonous things. And so you just immediately associate it with poison. And so let's find out how bad it really is methotrexate. It does have side effects, and these are the ones you may experience. Nausea and fatigue are by far the most common. Stomach upset, just feeling a little bit yucky is common, especially at the beginning, and it tends to get better over time. The first month might be a little rough, but then after that, it usually tends to get better. Mouth sores are common, and then rare liver toxicity and blood changes showing up on blood tests may appear, like low blood cell counts. Those are rare side effects, but your doctor, if they're going to prescribe it, will be testing for that. And they're usually reversible after you stop taking methotrexate. So from your doctor's perspective, it's not much of a concern. For other diseases like rheumatoid arthritis, the doctors who prescribe for people with rheumatoid arthritis consider methotrexate to be a much better option than prednisone as far as safety. They specifically think that methotrexate causes less side effects than prednisone. So if you're terrified of methotrexate side effects, your concerns are a little misplaced. You should be more terrified of prednisone side effects. My platform here is that I want you to do everything you possibly can to minimize your side effects from prednisone. And one of those things is to get on the lowest effective dose of prednisone. I want you to be able to thrive on prednisone and not just survive on prednisone. And so helping you understand that the risks of prednisone are actually worse than the risks of methotrexate statistically and according to the doctors who are actually prescribing these drugs. Methotrexate looks scary. I get it, but it's less scary than prednisone. Prednisone is truly a more scary drug. And as another professor at that event said, that prednisone and other glucocorticoids are the most harmful medications they prescribe in rheumatology. That makes it more harmful than methotrexate, right? In addition, they're also the best drugs they prescribe in rheumatology because it works so well to help the pain go away, just not necessarily keep it away, right? We've talked about the relapse risk. So for prednisone and methotrexate, the really most important thing is to keep the benefits and risks balance in your favor. You want to make sure it's actually working for you and that the side effects are less than the alternative of not being on the medication and having your disease untreated. So here's some practical advice if you are taking methotrexate. Typically, methotrexate is dosed once a week. Often people end up using it on like a Friday, for example. Every Friday, they'll take their methotrexate dose. So you want to first schedule it, like put a reminder on your phone to take methotrexate or put it in your pill box every Friday. Whatever it is, make sure you're not missing the dose. You want it to be consistent. Next, methotrexate is well known to cause some of the side effects because it's depleting folic acid from your body. Folate or folinic acid or methyl tetrahydrofolate, these are ways to describe supplements that you can take to give back what methotrexate is stealing from your body, leading to side effects like the mouth sores. And so if you're taking methotrexate for PMR, you also need to be taking some form of folate. My favorite is L5-methyl tetrahydrofolate, but there's also prescription folinic acid that your doctor can give you. Next, stay hydrated, especially that day that you're taking methotrexate. That can help your body process it effectively and may minimize the nausea. Definitely keep monitoring your health. Your doctor is going to be ordering blood tests. Make sure that nothing really bad happens from the methotrexate. So be sure to do those follow-up blood tests to make sure it's safe for you. Next, watch for side effects. Common side effects like fatigue or stomach upset are usually annoying, but not life-threatening. But if anything is concerning to you, be in touch with your doctor. Finally, combine it with lifestyle changes like eating an anti-inflammatory diet, getting good exercise, and minimizing stress. That can help to manage your PMR symptoms. So to summarize, methotrexate may or may not be a helpful alternative to prednisone or a way to minimize prednisone dose. It's just really controversial. And in Harvard, they don't do it anymore. But if you're wondering, well, I hate prednisone, is there anything else I can use for my PMR? I learned a whole bunch of what other things you can consider for PMR and at that Harvard seminar. So check out this video, other treatment options besides prednisone for PMR that I learned all about at Harvard Medical School. Just watch that video now. I went to Harvard Medical School for a seminar and I took questions from thousands of you. And some of those had to do with how do you tell a difference between a flare of the disease and prednisone withdrawal? And that question stumped every single professor and rheumatologist I talked to. And I posted a video about this question, and several readers and viewers sent in some insightful ideas. So I wanted to share those with you because if you ask your doctor, you might not get an answer. So let's talk about like what the problem is here, what the controversy is, so that you understand why the doctors didn't know how to answer. And then I'm going to share the fantastic, insightful responses from several emailers. So I asked the professors, what's the difference between prednisone withdrawal and a flare? And the biggest problem with that question is that it assumed that all the doctors appreciated what prednisone withdrawal is. And I shouldn't have thought that because I went to pharmacy school. I learned about prednisone. No one ever mentioned prednisone withdrawal to me. That was not a phrase I ever heard. And in fact, even when I first launched my career as a prednisone pharmacist, it was not something I appreciated either. And so there's a gap in medical education about the existence of prednisone withdrawal. Every doctor knows about opioid withdrawal from pain medications, or alcohol withdrawal, or benzodiazepine withdrawal from things like Xanax. These things that are well established and appreciated, but doctors don't appreciate the fact that, like all of those medications, your body creates a dependence on prednisone. You are artificially replacing cortisol. And when you withdraw that, it creates a withdrawal syndrome, pain and misery that I've described in further detail in many other videos. But somehow that isn't being taught, even though it's legitimate. There are medical articles, scientific, peer-reviewed articles all about this. It is a legitimate thing. It's just not appreciated by the doctors who aren't going through it. So that was the first problem, is that they don't appreciate it. And so then asking them, how do you tell the difference between it? They're like, there isn't withdrawal. It's just adrenal insufficiency. I'm like, no, it's not. Because adrenal insufficiency is the inability to make adrenal hormones. Everyone on prednisone has that. You've turned off that ability. Anyway, I'm not going to get into that rabbit hole. We're going to get to solutions now. So they don't appreciate the problem. Therefore, they haven't thought of the solution. Does that make sense now? But those of us who have thought about the problem, especially those of you who watched that video, did think of a solution. So I'm going to read the first one. This is from Dr. John Watkins. He said, I am a retired internist. If you don't know what that means he's a physician, a doctor, a medical doctor. And he did like internal medicine, things like giving people prednisone. And he's suffering with PMR. It would seem to me that a way to differentiate PMR flare from prednisone withdrawal syndrome is by checking markers of inflammation, such as sed rate and CRP. Inflammation should be increased during a disease flare, but at baseline during withdrawal. Please correct me if I'm wrong. I love your emails and blog, JW. That was the first one. Here's the second one. Dear Dr. Megan, we watched your Harvard video. We are wondering if sed rate and C-reactive protein tests would distinguish between a PMR flare and prednisone withdrawal. What do you think? Your fans, Anne and Robert. So I think this, coming from two totally different groups, makes perfect sense to me, that the symptoms, what you personally feel, might be very similar. Pain, achiness, yucky feeling. But the way to tell, is it withdrawal or is it a flare, is to get a blood test. So you can't tell yourself. You have to have your doctor order a blood test, and it would be for those two markers, inflammation, CRP, which stands for C-reactive protein, and ESR, which is erythrocyte sedimentation rate. Both of these measure things that get bad in your blood. They're just markers, like, oh, a bomb went off. See the smoke? They're like the smoke. You can see the smoke because these are in your blood. So I think this makes perfect sense to me, that withdrawal, you should feel bad, but your blood should look good. Whereas a flare, you should feel yucky and your blood should show that you're feeling yucky because it's a flare. What do you all think? Any other rheumatologists out there willing to venture a guess who appreciates this distinction sufficiently? Let me know in the comments what your thoughts are. I love crowdsourcing problems so we can find solutions. And then if you have any other questions you want crowdsourced, you could also leave those in the comments. And if you want to watch the original video of all the things I learned at Harvard, just click this link and you'll see that video now. Wondering how to taper prednisone for PMR? I'm Dr. Megan, the Prednisone Pharmacist, and I got lots of questions from people wondering how to taper off prednisone if you're taking it for polymyalgia rheumatica. Now, this is specific for this disease, but a lot of what I'm going to say is applicable to anyone taking prednisone for any disease because it's the principles of the drug itself. But there are a few nuances about PMR specifically that I wanted to touch on because there are so many people on prednisone for PMR for so long. So you have unique challenges that I want to help you overcome right now. And I've had several prednisone warriors reach out and tell me their story. So I want to incorporate some of their stories as well. I did a long interview with a woman named Diane who has PMR, And her story is really helpful. And another woman responded to that with some tips for maybe what Diane could have done differently. So I wanted to share that. So generally, PMR, polymyalgia rheumatica, is a condition of inflammation and pain in the shoulder and pelvic girdle area. Other joints can be affected, but those are the main places, leading to an inability to lift a cup to your mouth, latch your own bra, all sorts of miserable consequences from incredible shoulder pain. And it usually happens to women over the age of 50 of Northern European descent. That's the stereotypical person, although it can happen in men and it can happen in other populations, but the most common are basically white women. So you might first wonder, okay, I've got this diagnosis of PMR. How long am I going to be on this? It's just a month, right? No, unfortunately. That's what I thought for my condition too. I thought, oh, it'll just be like 10 days and then I'll be off. No, it was 9 months for me. For my condition, which is not PMR, mine's called ITP. But for PMR, they've done several studies, and this is one of them. It says the mean duration of steroid treatment for all patients was 30 months with a range of 13 to 108 months. So that could be about a year if you're lucky, or it sounds like one of those was on it for almost 10 years. Every person's different. They said the higher the ESR and CRP on diagnosis, those are blood tests that show inflammation. ESR stands for erythrocyte sedimentation rate, and CRP stands for C-reactive protein. The higher those were, generally in this study, the longer the duration of prednisone treatment. So that's a really interesting association to see that basically the more inflammation you have, the longer you're going to need an anti-inflammatory medication like prednisone. It makes sense. And so with that, about how many people? So I saw one study that showed about half of people, this is a different study, half of people are on prednisone for a year. Another half of those are on prednisone for 2 years, and another half of those are on prednisone for 3 or more. So basically it's a half-life of 1 year, if you know how half-lives work. But the prednisone itself has a half-life of 2 hours. So this is really helpful to know that this is a very long-term plan. Your next question might be, when is prednisone going to kick in? And one study showed a woman responded after 12 hours of treatment. Other people have said 2 to 4 days. Another have said within 2 weeks, you should definitely have a response. And if you're still having pain after that long, maybe the dose isn't enough. What dose would you normally take? Somewhere between 15 and 25 is what the guidelines say is where the doctor should start your dose. But everybody's unique and everybody has a dose that is going to work for them. And your goal is to find whatever that dose is that is the lowest effective dose. So you could start out at 25, but then you'd want to drop until you get to a point where maybe the pain's coming back. And then you go back up to wherever that dose is not causing pain for you. So it's somewhere between 15 and 25. For some people who have other inflammatory complications, like for example, if you have giant cell arteritis overlaid with it, giant cell arteritis acronym is GCA, and there's a higher percentage of people who have GCA and PMR. They're correlated. Sometimes PMR can lead to GCA, sometimes GCA can lead to PMR. There's an overlap in the type of person who gets these diseases. And so if you originally come in for PMR and you actually might have underlying GCA that isn't treated, maybe you actually need a higher dose to overcome that more inflammatory condition. And just what GCA is, it's inflammation of the arteries, typically the arteries here, and it's called temporal arteritis. And it's painful, can lead to headaches, vision loss. And so doctors are very aggressive in treating it with pretty high doses, usually somewhere between 40 and 60 milligrams for that disease. So if you're not getting pain relief from your PMR, maybe you need to go up in a dose. And always, everything I'm telling you is working with your doctor closely. I do not replace your doctor. You definitely need to be in close communication with either your rheumatologist, if that's the person treating you, or your primary care doctor. And while we're talking about doctors, it's really important that you get the accurate diagnosis. PMR is kind of a diagnosis of exclusion, making sure it's not other things first. You wouldn't jump straight to a diagnosis of PMR without a blood test, without ruling out rheumatoid arthritis and several other things. So you'd want to make sure that if you're in any doubt whether this is your diagnosis, like if the prednisone isn't working, then get a second opinion. Like, do not hesitate to get a second opinion, because if it truly is PMR, typically prednisone works miraculously. Like, you're in agonizing pain, and then suddenly the prednisone kicks in and you have relief. You're able to function again. You have energy. You have enthusiasm for life at first. So definitely get a second opinion if this isn't working for you. Okay, so now at this point, you have found the dose that is working for you, the lowest effective dose that is helping. You're getting the pain relief, and the reason we want it to be the lowest effective dose is because prednisone comes with lots of side effects. I'm talking more than any other drug. A professor at Harvard, where I learned about PMR and GCA and other forms of vasculitis, he said that prednisone and other steroids are the best drugs in rheumatology because they work so miraculously. And they're the worst drugs in rheumatology because they're so horrific in the side effects that there's nobody who wants the person off prednisone more than their doctor, aside from the patient itself, because the patients, we are the ones experiencing the horrific side effects. And the doctor knows that there are so many terrible possible consequences. So what are these consequences the doctors are worried about? Well, it's anything from head to toe. Check out this image of my side effects. It can be anything from mood changes like anxiety, psychosis, depression, to heart disease, stroke, heart attack, arrhythmias, bone issues, whether it's bone loss, osteoporosis, or osteonecrosis, bone death, diabetes, high blood sugar, weight gain, all sorts of metabolic complications, insomnia, and on and on. So many possible changes that you definitely want to minimize by getting on the lowest effective dose for you. You don't want to go below that, otherwise your disease flares and the inflammation gets worse. You want to find precisely where your disease is under control and you're minimizing your risk for these side effects. So now that you've figured out what that lowest effective dose is for you, what is the plan from here? Well, working with your doctor, you could do some of the following things. You would want to find a way that the drug is working at the best time of day for you. So typically PMR has the worst pain in the shoulders upon waking. And so you'd basically want to figure out a way that the drug works when you're waking up. And there are several strategies of how to do that. You could take prednisone like most people do with other diseases first thing in the morning to mimic cortisol. That is what most people do for other diseases, but not necessarily for PMR. Because PMR has that early morning pain, some people change the way it's dosed. And instead of taking it first thing in the morning only, they may also take a bedtime or a middle of the night dose. So let me read the story that I alluded to earlier. This was the response of how this woman had figured out how to get to the lowest effective dose using an interesting dosing timing. So I'm going to just read her story. I suffered for many weeks with my husband helping me to get out of bed before a very astute physician knew exactly what it was. Started at 10 milligrams of prednisone, then was up to 15 milligrams 2 weeks later, and that controlled my pain. During those 2 weeks, I tried various dosing times. Initially at breakfast as recommended, but the pain started returning by bedtime. And then the breakfast dose took a while to give some relief. The typical dosing with prednisone does not take into account the morning pain with PMR. Dosing at night helped me to go to bed without pain, so it didn't build up overnight and completely stopped the morning pain, but I didn't sleep. After doing a lot of online research of medical reports, I found several studies and articles talking about their circadian rhythm, suggested dosing in the middle of the night for PMR specifically because of the morning pain. And she's quoting a study now. The body normally produces cortisol between 2 and 3 a.m., which can then counter the cytokines that are produced between 4 and 4:30 a.m. One study compared the dosing at 2 a.m. versus 6:30 a.m. and found there was much less morning pain with the 2 a.m. dose. And another study, not in PMR, but in rheumatoid arthritis, showed that administration of low doses of prednisolone, 5 or 7.5 milligrams daily at 2 a.m. had favorable effects on the duration of morning stiffness, joint pain, and morning serum concentrations of IL-6. That's an inflammatory marker. She continues, that worked well, but I would start again with some shoulder pain at supper time because the early morning dose had worn off. Doing a split dose, as suggested in a PMR forum, was my answer. 10 milligrams at 2 a.m. and 5 milligrams at 6 p.m. I could sleep well until my dose, had a tolerable amount of sleep disturbance after that, and awakened with no pain. After 1 month at 15 milligrams and finally seeing a rheumatologist, he started my tapering by 2.5 milligrams every 2 weeks until I hit 10 milligrams, then by 1 milligram monthly. I gradually reduced both splits until I was down to 8 milligrams in a single dose at 2 a.m. Even 2:30 or 3 a.m. was okay, giving me better sleep for a bit longer each night. Like Diane, I found I had to listen to my body. I needed to go down very gradually by 0.5 milligrams the first week of each month, then could finish the month at the desired target dose. This last taper to 6 milligrams was further complicated by the time change, but I have been okay now finishing the month. Each month now will be a new experience. I loved this story because it showed a lot of principles of PMR, tapering, and dosing. So she talked about the split dosing that I mentioned, that it's got a 2-hour half-life. So it's basically completely gone after 12 hours. So if she's taking it at 2 a.m., by the evening, it's pretty much gone. And so she needed just a little bit more. I'm not saying you need to follow her strategy, but she did say you need to listen to your own body. And I fully agree with that. Every single person with PMR is different in how long they're going to be on it and what dose works for them and their inflammation and pain. I also appreciated how she described her relationship with her rheumatologist. She finally got to see them because rheumatologists are often booked out really far in advance. And the way that rheumatologist tapered the prednisone was exactly what is recommended, not only by the Harvard professors that I learned from, but also by the guidelines written by the European League Against Rheumatism and the American College of Rheumatology. And that is that before 10 milligrams, you can taper by about 2.5 milligrams a week. So for example, if you were to start at 15 milligrams, the next time you drop, you could drop to 12.5 milligrams. And potentially the next time you could drop to 10 milligrams. But at that point, you do not continue dropping by 2.5 milligrams. That is way too much of a dose drop. And that is because the drop is more important that we consider the percentage drop instead of the actual milligram drop. When you're dropping from 12 to 10, that's about, 2 milligrams is about somewhere between 10 to 20%. And that's the goal we want to go for. But when you drop from that, the same 12.5 to 10 is 2.5 milligram drop. And then if you were to go from 10 to 7.5, that 2.5 milligram drop is actually 25%. That's actually twice, like a humongous drop. Percentage-wise, you want to keep it lower, between 10 to 20% when you're dropping, especially with PMR. She was mentioning she was only being able to drop by 0.5 milligram, so 0.5. And that's pretty common as well. So some people can tolerate a drop from 10 to 9, 9 to 8, 8 to 7, and so on with PMR. Others have to drop by 0.5 milligram at a time. And each of those drops is over a month. And there are several ways we can do that. So let's talk about ways to drop. So you could just drop straight from 10 to 9. And just one day you were taking 10 and the next day and thereafter you take 9 milligrams. Some people can tolerate that. Other people have to be a little bit more nuanced. And that's where every other day dosing comes in, or every few days. So that's where you might go from 10 on day 1 to 9 on day 2, 10 on day 3, 9 on day 4, 10 on day 5, whatever number we're at. But every other day, you're going back and forth from old dose to new dose, old dose, new dose, old dose, new dose. And you just do that for as long as needed until you're tolerating that drop. Because essentially, when you're doing it like that, that's basically a 0.5 milligram a day, right? When you average it over 48 hours, you're only dropping a 0.5 milligram. So that's a possibility. Other people have to extend that even further. Instead of every other day, it's every few days. So it would be old dose, new dose, old dose, old dose, old dose, new dose, old dose, old dose. It would be like every 3 days or something. And then you can make it even smaller and smaller as time goes on, the timing between it. There's an amazing resource that has many different tapering schedules on it, strategies that have been mentioned in guidelines and in support groups. And I'll have a link to that in the notes for this video of this taper resource that you can just plug in what dose you're on, and it can spit out a schedule for you using one of the built-in taper plans that others have put into their system. So that's another strategy if this is a little bit too complicated for you. And then in order to be dropping by, from 10 to 9, you do need access to 5 milligram tablets or 2.5 milligram tablets or 1 milligram tablets. Essentially, you really have to have access to 1 milligram tablets. And can you split these in half? Yes. So you could technically take 9.5 tablets if you wanted. You would take like a 5 milligram tablet and then 4 1 milligram tablets and then a half 1 milligram tablet. You could do that. That's a possibility. Or you can do that alternate day dosing. Working with your doctor and listening to your body are the really most important keys here. And I am available for consultations if you absolutely need it and you've exhausted all the resources you already have. I'll have a link below to that as well. I can consult on what you can discuss with your doctor. So in addition, I have a free prednisone taper chart. And I have that extended taper that's over a year that you can refer to as a possibility for how to taper prednisone. It's got short-term tapers, longer-term tapers, and the longest-term taper. And it includes that every other day dosing. So you know exactly what to do. You can just, mark things off as you get them done every dose that you take. It's free, it's printable. Just click the link below to download that now. And how do you know if it's your disease flaring or you're sick or you're in prednisone withdrawal? And that's a super tricky question. And I asked it to the professors at Harvard and they didn't really have a great answer, but crowdsourcing it, I got some answers. And I think what one person suggested, and it's, do I watch CRP levels, watch pain levels? I think the combination of listening to your body, watching your pain levels, and potentially getting blood draws to see if your inflammatory markers are going up, your CRP or your ESR. And if they are, then clearly that's your disease flaring and you're not going into withdrawal. But if you're just feeling yucky and you're not getting that pain and it's just a blah feeling, low energy, that's probably more likely withdrawal. The treatment for either of them is the same. Go back to the lowest effective dose where you weren't feeling yucky, where you weren't having pain, and then start again to taper at a much slower rate after totally stabilizing. Never try dropping a dose if your pain isn't totally under control. There's no point in trying to fight it. You're not going to win. The inflammation is too dramatic to try to push it. And so if tapering that long sounds horrendous to you, and being on prednisone sounds horrific to you for that many years, luckily, in the last few years, they've recently come out with some alternative medications to prednisone or, supportive medications, what they call steroid sparing, allowing you to get on a lower dose of prednisone. And these include Actemra, which generic name is tocilizumab, and Kevzara. And there are a few more under investigation that may help. I've made other videos all about these, so you should check those out. But essentially, talk to your doctor about getting on these biologic injectable medications if prednisone is so intolerable to you. Because for me, it was intolerable. And for many people, it is definitely intolerable. One study of giant cell arteritis showed that the lowest effective dose on average was 9 milligrams, but the dose where the side effects were tolerable was 5 milligrams. There was literally no golden dose where the benefits outweighed the risks. It just fails so often. It doesn't actually keep people out of remission with giant cell arteritis. And so finding that balance is a really tricky question and may be impossible to find. And so luckily we have these injectable biologics that can help some people, not everybody, but at least for most people, they allow you to get on a lower dose of prednisone. So talk to your doctor about that. And again, if you need help tapering prednisone, click the link below to download my prednisone taper chart. Wondering when prednisone is going to work to help with PMR? And when does it fully kick in? When do symptoms go away? If you are just brand newly diagnosed, what can you expect as far as how long you're going to be taking prednisone for PMR? These are great questions that I've been asked by many people, and I've learned the answers while I was at a Harvard Medical School seminar. So I wanted to share what I learned and give you an overview of what to expect while taking prednisone for PMR. I'm Dr. Megan, the Prednisone Pharmacist, and here are some of the things I learned and what you need to know about prednisone for PMR. So a prednisone warrior named Matt provided some questions that are going to frame my answer. And so I wanted to read his questions first so that you understand the context of what I'm trying to answer. This is what Matt said. Hi, Dr. Megan. Thanks so much for your PMR content. I hope it's okay to ask you a couple of PMR-related questions. First, do patients often see a 100% or complete disappearance of PMR muscle symptoms when taking prednisone, aka getting treated? Or, as an example, do most patients observe a lower number of muscle stiffness, pain reduction, stiffness, like 75% or 50% reduction, for example? So that was his first question, is like, how much disappearance to expect? Second, how often do patients get their PMR into full remission when taking prednisone? And what is the average time for patients to achieve full remission of all symptoms? Thanks again. I was just diagnosed yesterday and I have a good doctor, but I'm also processing a lot. Any help you can provide is greatly appreciated. I hope this finds you well, Matt. All right, Matt. So like I said, I went to Harvard Medical School and I learned from Harvard rheumatology professors, doctors, the experts in the field. And these are some of the things I learned. So to briefly answer your first question is, do you get like 75% or 50% or 100%? Usually prednisone is a miracle drug for people with PMR, and it usually makes the symptoms completely go away. That's what most people experience. Let me read the exact words that the doctor used. He said, glucocorticoids typically lead to dramatic improvements in symptoms within the first few days. Other like actual words of people include like, it's a miracle, I can't believe it. I went from like, I can't do anything, I'm totally impaired, I can't even get out of bed without dramatic pain, to I'm back to normal. Like normal PMR treatment with prednisone is amazing. It is truly a miraculous medication. So let's go over the typical treatment guidelines that you can expect for if you're diagnosed with PMR, then what? Then what? Then what? Okay, these guidelines were created by the European League Against Rheumatism in 2015. So they're kind of old. There's a lot that's changed since then, but the general strategy when it comes to prednisone and PMR is still the same. So first, you're diagnosed with PMR. And it's really important that this is a really good diagnosis, that lots of other things are ruled out to make sure it's not some other disease, because then what I'm about to tell you isn't going to work as well. So right at diagnosis, once we've made sure it's not other things, start prednisone. And the dose range is anywhere from 12.5 to 25 milligrams a day. Notice that's 25 or lower. Like it's not 40, 60, 100 milligrams. If you're getting that high of a dose, that's really too much for PMR. And it's kind of overwhelming, unnecessary, unless you have something else going on, like, for example, giant cell arteritis with your temporal arteries being inflamed. So then you stay on that dose, whatever your doctor prescribed, somewhere between 12.5 to 25 milligrams. Stay on that for 2 to 4 weeks. And then you gradually taper about 2.5 milligrams at a time until you get to 10 milligrams. So say you started at 20 milligrams So then over 4 to 8 weeks, so you could drop by 2.5 milligrams every week or every 2 weeks. So you went from 20 to 17.5 to 15 to 12.5 to 10. And you dropped that far over a month to 2 months. Okay. And then at that point, you taper really slowly, about 1 milligram per month or even slower until you're off. So that means 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. That, if you caught the math there, that's about a year of treatment. Okay. That is essentially the minimum to expect from PMR. If you are able to follow that exact tapering strategy with no problems, count yourself very lucky, because for most people that doesn't really work, but that is the general strategy. So your second question, Matt, is how often do patients get their PMR into full remission when taking prednisone? So most people who take prednisone for PMR get full resolution of symptoms. Do they get fully off of prednisone? Not so much. What is the average time for patients to achieve full remission of all symptoms? So this is kind of an ambiguous question. Is it full remission with prednisone on board, or is it full remission with no treatment, right? So I'm going to answer the first one. Full remission because you're taking prednisone, like you're having these horrific symptoms, your muscle pain, your shoulders, you can't lift a cup, you can't do anything for yourself. You're totally, essentially disabled with incredible pain. That usually fully resolves with prednisone treatment, sometime between 12.5 to 25 milligrams. And if it doesn't, then either on your too low of a dose, or maybe PMR is not the accurate diagnosis. One doctor has said that if prednisone works, you have PMR. Like if it doesn't work, you don't have PMR, is one way to simplify it. It's not necessarily that simple, but it's kind of a good distinction that prednisone works for most people with PMR. If it doesn't work, it's time to revisit that with your doctors, because it should work for pretty much everybody, or you don't have PMR. Let's finish answering the first way you asked about it. What is the average time for patients to achieve full remission of all symptoms? So there's not a lot of good research on this, but one case report showed a woman who had like weakness, muscle pain, dramatic, horrible feeling, went to the hospital, they did all these tests, gave her prednisone 20 milligrams. 12 hours later, she feels like fine. Her muscles strong and not in pain. 12 hours. That was it. That was all she needed. Whereas other people, it might be up to 2 weeks before they feel the resolution of symptoms. But for most people, it's within a few days. So that's why the treatment guidelines by the American College of Rheumatology and the European League Against Rheumatism says 2 to 4 weeks, you should be getting symptom relief. So it's anywhere from 12 hours to 4 weeks where you could be getting a symptom relief, but most people, it's really rapid. Okay, so then what happens if you relapse? If the disease comes back while you're trying to taper, then the guidelines say to increase to the lowest effective prednisone dose. So if you had started at 20 and you went to 17.5, 15, 12.5, 10, and you get to 9 and suddenly, oh, it's getting achy. You go back up to 10. Wherever you were and you weren't having problems, you go back up to whatever that was. So if you keep doing this roller coaster that I personally had to deal with when I took prednisone for a different autoimmune condition, if you keep relapsing when you're trying to get below a certain dose, then they say manage as refractory PMR and consider alternative treatment strategies. And that didn't used to be a possibility until the last 5 or so years, when new treatment strategies have come out. And I share those in a different video. Check those out. But who is at risk for relapse? So one study showed the higher relapse rate or being on prednisone for a really long time was most likely in females with a high ESR. So that was one of the blood tests. If it's over 40 when you're first diagnosed, you're more likely to relapse. And if you already had before diagnosis, what they call peripheral inflammatory arthritis. So if you have like wrist, finger, or other types of arthritis, you're more likely to relapse. Now, this information is a little kind of depressing about how likely you are to relapse if you have PMR. And that's why I was showing you at the beginning, this is the ideal taper, but it doesn't work for most people. These are the actual statistics according to one study. It said there's a high rate of long-term glucocorticoid, and when it says that, I'm just going to substitute prednisone treatment, is recorded in polymyalgia rheumatica, being 77% are still on prednisone at 1 year, 51% at 2 years, and 25% of patients with PMR are still on prednisone at 5 years. That's kind of sad. They said there's a pooled relapse rate of 43% at 1 year, which is remarkable. So the number of years you're on prednisone doesn't necessarily have to do with your relapse rate, right? Like you could just be prescribed prednisone long-term and your doctor might not even trying to get you below whatever dose and trying to relapse, like trying to see if there's a relapse happening. But 43% of people in 1 year did relapse at some point. And so like basically had to go back up to the lowest effective dose. And several studies have attempted to identify potential predictors of prolonged treatment with glucocorticoids in relapse, but with inconsistent results. Basically, there's not enough evidence to show us why people are relapsing and like how to predict who's going to be on it long term. There's not a lot of good evidence, but the other thing I shared was women, high ESR and arthritis may, but it's just not good evidence. So here's two different arguments for and against using prednisone long-term, okay? So who should use prednisone long-term with PMR? Those who cannot tolerate or have a contraindication to other treatments. Like, for example, you've tried methotrexate and it gave you horrible nausea and vomiting and you just couldn't tolerate it. Yeah, don't bother even continuing methotrexate, just use prednisone. Or those who have optimize the use of long-term corticosteroids, it's going to be a lot cheaper to be on prednisone. Like if cost is a real issue to you, like you don't have insurance, you're not on Medicare, the other alternative medications can be very expensive. Like Actemra is tens of thousands of dollars a year. And then other people who probably have less risk for complications are those who have good glucose control. So you like have no family history of diabetes, you have a healthy weight and your healthy blood sugars. You have low cardiovascular risk, like no family history of heart disease, and then low osteoporosis risk. So you're not a postmenopausal female. If any of those things aren't true for you, then it's really not actually safe long-term. So here's the argument against it, okay? Another argument could say there are no scenarios where long-term use of prednisone is justified. And so all of these people should have caution against using prednisone long-term. Those with osteoporosis, diabetes, glaucoma, joint infections, uncontrolled hypertension, that's like high blood pressure, those with peptic ulcer disease, congestive heart failure, and active infections. Yikes. A lot of people have all of these things or some of these things. And the older you are, the more likely you are to have these things. And the older you are, the more likely you are to have PMR. So it's really tricky to find someone who doesn't have those risks and isn't going to have those risks nearly coming with their age becoming older. It's a tricky situation. So there were 2 studies to see how many patients with PMR got side effects that were like notable. There were 2 different studies looking back to see, for those who took prednisone long-term, how many got side effects. And it said that 65% of patients, which was specifically 81 out of 124 patients in one study, and 43% of patients, which was 95 out of 222, experienced at least one adverse outcome. And so basically these are people who had an infection, had broken bones, had heart disease, had glaucoma or cataracts, or many of the other 150 side effects that were bad. And so in one study, most people got side effects. In a lot of other studies, most people get side effects. It's not if, it's when you're going to have a side effect. Most people get them at the beginning, and especially as time goes on, the risk for heart disease, bone issues, all increase. So for those who are taking prednisone for PMR, I've given you a little overview of what to expect, some of the risks, some of the benefits. Like, it's amazing. It's a miracle, truly. And if you're thinking, wow, what can I do? I have a little cheat sheet for you. I call it my Prednisone Checklist. And it includes the top tips for what you can do about these many risks for complications that there are things you can do to minimize your risks for having broken bones, having your eyesight worsen, having your heart disease worsen, that there are actual things you can do, you can talk to your doctor about doing. And I want you to be empowered to be able to do whatever you can to be able to take prednisone like you need to and not have to worry too much about it. And so I include those in my checklist. So there's things that you can do, things that your doctor can do, and then you can feel confident that you're doing exactly everything you can to minimize your risk for complications. Just click the link below to download my prednisone checklist now. How would you like to go from embarrassment from prednisone side effects to stability and normality, feeling like yourself again while taking prednisone for conditions like PMR? Well, today I want to share a series of reviews from a person with PMR who shared his journey while taking prednisone, Nutrinizone for PMR. This is Nutrinizone, this is prednisone, and he had to take them both. And this one made him feel horrific. And then we put them together and he felt normal again. And so I wanted to read you his story. These are all his words. So without further ado, this is a video I recorded for him when he announced that after 2.5 years of Nutrinizone, he is done because he finally tapered off of prednisone. So he no longer needs the Nutrinizone. So without further ado, these are Craig's words about his experience taking Nutrinize. Craig, I'm so glad to hear that you are graduating from taking prednisone. What a journey you've been on over the last several years of taking prednisone and then taking Nutrinizone alongside it. I just wanted to read your note because it is so sweet. You said, "It is bittersweet to have to write to you to cancel my subscription as of today. I'm not one for hyperbole, for it diminishes everything one says. So please understand that I can sincerely say you have saved my relationship with my wife and my sanity. I am now down to 0.5 milligram of prednisone and the horrible side effects have finally left. I say bittersweet for I want people who do sincerely good for others do well financially. However, my role now is to endorse your product at every chance. Thank you again, Craig Helgerson." Thank you, Craig, for endorsing my product at every chance and for your ongoing support. These other reviews you left are so amazing, and I'm so grateful you left them as well. So the first one you left was on December 14th, 2022. You said, "Blah, blah, blah is all I have heard from overpriced supplement companies over the last 40 years. I've tried many with no appreciable effects until now. I was recently diagnosed with PMR, so I was put on prednisone. I went from a relatively normal, sane, and lucid person into someone who by the end of the day felt horribly bad for being unreasonable, critical, and combative toward everyone around me. I would start each day telling myself that today I will not behave like a paranoid jerk. Jerk really stings, but my wife says this was the most accurate description for how prednisone turned me into. Out of absolute desperation, with little hope, I learned of Dr. Megan and Nutrinizone and went ahead and ordered some. Within 24 hours, the craziness that would come out of the ether each day stopped showing its ugly face. Now for over a week, I have returned to the wonderful, cuddly, lovable, well, maybe that's a little much, man that I have been for many years. Seriously, this has absolutely, all caps, improved my quality of life from dystopian embarrassment and shame to stability and normality. Thank you, Dr. Megan." You're welcome, Craig. And then a couple weeks later, you left this review on December 28th, 2022. "I purchased a sample bottle last month and wrote a review where I spoke of how horrible irritability evaporated." Try saying that 10 times fast. "This is my second month and I stopped looking for any additional improvements. However, to my surprise and delight, my moon face left this past week and my weight has fallen back to my pre-prednisone level. All the ugly fat above my waistline has evaporated also. I'm sure I'll wake up in a few minutes and find it was just a really nice dream." Well, Craig, I'm so glad that it wasn't just a really nice dream. I'm so glad that it was real for you and that it sounds like your PMR is in remission and you are doing well at just 0.5 milligram a day. That is so amazing. So fantastic. I mean, your story sounds pretty typical, starting in 2022 and ending in 2025. 2 to 3 years is a pretty common amount of time for people to be stuck on prednisone for PMR. So your journey sounds like you're totally normal aside from the one thing, and that's that you chose to take Nutrinizone along with your prednisone and not have to feel so horrible. So I'm so glad that you were able to get this support the whole time you were on prednisone, and that you are graduating. Oh, cross my fingers that you stay in remission and that your awful PMR pain stays away. Thank you for your support of Nutrinize, and best of health and healing to you, Craig. Are there any other treatments for PMR besides this horrid drug, prednisone? I was asked some variation of that question by many prednisone warriors who are stuck on prednisone for polymyalgia rheumatica. And so I wanted to share what I learned at Harvard Medical School from a Harvard professor of rheumatology, all about alternative treatments for PMR, new treatments that are being researched right now, that are on the horizon, and hopefully within the next few years will be approved, and we'll have so many more options besides just prednisone and the horrible side effects that accompany it. So some of the other questions people asked were, if I start to experience PMR symptoms in the future, are there any non-steroid treatments available? Another, are there really no other options for PMR other than prednisone? Any new treatments? Okay, another one, is there something else that has less horrible side effects? The best PMR option when prednisone has not worked after 5 years. What other treatment options are there apart from prednisone? So let's get these questions answered based on exactly what I learned from Professor Sebastian Unizzoni from Harvard Medical School. And he's a professor of rheumatology. So he went through all of the studies for all of the possible treatments and how effective they were. And so he just kind of went in order of when the studies were published. And that doesn't necessarily mean how good the drugs are. So it's just following it over the time. So the first one that is an alternative to prednisone that's been around for quite a while is methotrexate. And this medication is often used in other rheumatological conditions. And a study 20 years ago showed it was really successful. But then they did a newer study in 2022, and it showed no difference compared to placebo. So does it help? Does it not? For some people, maybe. But for other people, it does nothing. Like, it does not help get you off prednisone. This drug is very promising, and I'm happy about this one. Actemra. Actemra, the generic name is tocilizumab, and they did a study looking for glucocorticoid-free remission at 12, 16, and 24 weeks, so 4 to 6 months. And they found that at week 12, 57% of people who took Actemra were in remission. At week 16, 63% were in remission. And at week 24, 57.9% were in remission. So hovering somewhere around 60%. It's working for about 60% of people. So that's really promising compared to the amount of people who are just taking prednisone. There were 17.6% at week 12, 11.8% were in remission at week 16, and 17.6% at week 24. So it's 5 times better than prednisone for getting into remission at those weeks. And then they did another study in France, and they found that 67% of those taking less than 5 milligrams of prednisone were in remission at week 24 versus 31% of those who were taking placebo. So this one was comparing placebo. So 67 versus 31%. That's pretty good. All right, here's another one, Kevzara or seralutinib. And they did a study showing 28% sustained remission at week 52. So that's at a year versus 10% on placebo. So it's about almost 3 times better than a placebo drug. And what was really important was the amount of prednisone they were able to get off. So the phrase steroid sparing, like making it so you don't have to take so much prednisone, is an outcome on its own because of all the horrible side effects of prednisone. So for this one, they showed that if you were taking Kevzara, you only, on average, got 777 milligrams of prednisone over that year, versus if you were on the placebo, you got 2,044 milligrams. That's good. And then they did another study, it was a real world study looking at actual claims information from Medicare of people who actually took Kevzara or Actemra or methotrexate or another drug called leflunomide. And they compared those two, they're called IL-6 receptor inhibitors, versus methotrexate and leflunomide, comparing those. And 47% of those were off of prednisone with the IL-6 receptors, Actemra or Kevzara, versus 33% were off of prednisone with the methotrexate. So that's pretty good. It's not like amazing, but when they look deeper into the data and look specifically at frail people with PMR, they said there was a greater glucocorticoid sparing effect by 1 year seen in frail PMR patients. So if you have PMR and prednisone is horrific to you and you're frail, these are a great option for you. They aren't perfect for everyone, but hopefully they minimize the amount of prednisone you have to take. Okay, so now we're going to talk about some other rheumatoid drugs that are expensive, biologics, that they're just trying to see, does it work in PMR? Because, did you know this? That PMR is the second most common rheumatological condition after rheumatoid arthritis. I didn't know that. I'd actually never even heard of it. Nobody mentioned it in pharmacy school, even though it's the second most common. Okay, so this one is called Xeljanz, and its generic name is tofacitinib. They did a phase 2 trial, and it didn't show that it was any better than prednisone. So that's too bad. Then Rinvoq or baricitinib, they did a study in France. It was a phase 2 double-blind placebo-controlled trial. And they looked at week 12, and 78% of those who were in the study were at low disease activity versus 13% were at placebo. That is huge. It said that's a relative risk of 5.8. Like, it's almost 6 times more effective than prednisone, Rinvoq. So let's hope it gets FDA approved so that your insurance will pay for it, because that sounds amazing to me. And they showed that the onset of action was at week 4, which I'm surprised by, because normally we're talking like 6, 8, 12 weeks before you see these drugs kicking in, and it's showing week 4. That's amazing. So then another drug called rituximab, or the brand name Rituxan, I personally had to use this to get into remission for my own autoimmune condition. And they did a study in Netherlands. And this one was, again, a phase 2 placebo-controlled trial. And they were looking, again, for low disease activity for glucocorticoid free. And they showed that at week 21, 48% of those in the rituximab group versus 21% of those in placebo group were low disease. So it was about twice as effective. And the other outcome that I love is how much less prednisone a person needs. So in the placebo group, they ended up on about 2,302 milligrams of placebo over that time period. But in the rituximab group, they only needed 1,595. So that's a big difference. And that is a big difference in a person's life and risk for side effects. Moving on to Orencia, or generic name abatacept. This was another study in France, and it was phase 2. And they found 50% of those got low disease activity on Orencia versus 22% on placebo. Again, about twice as effective as placebo. They tried another one, and it's ABV, this dash number. But basically what I think it is generic Humira with a little molecule attached to it that's called a glucocorticoid receptor modulator. That's new and interesting because prednisone is a glucocorticoid. So if we're modulating the way it's touching, that might minimize the side effects of prednisone. So that's cool. And every single dose that they tested showed much better. I think the highest dose got 78% of people benefit. Really good news. So those are all the drugs that he mentioned in this presentation at Harvard Medical School I went to last weekend. And then his last slide was, these are the phase 3 trials. So these are the ones that are getting close to FDA approval for polymyalgia rheumatica. Besides this horrid drug, prednisone, Rituxan, which is rituximab, Xeljanz, which is tofacitinib, and Arava, which is leflunomide. And of all of these options, you might be wondering, so do I have to inject myself, or do I have to go to an infusion clinic? Is it any of these pills? And I'll tell you, these are the ones that are oral, that you can swallow as a pill. Tofacitinib, which is Xeljanz, leflunomide, and Rinvoq. Those are all oral pills that you'll be able to take. Besides this horrid, I think it would be so amazing if we could get Rinvoq approved, because it was like almost 6 times better than placebo, getting people into remission. And that sounds amazing. And same with the Xeljanz. Tofacitinib was not good. That would not help. Tofacitinib showed no better. We want Rinvoq to get FDA approved for the oral pills so you can take that instead of prednisone and not have to inject yourself. And it's going to work for a lot of people and minimize your steroid side effects. So for all of you people who asked, is there anything else I can possibly try besides prednisone? Now you know the latest, greatest information from one of the foremost researchers in the field, Dr. Sebastian Unizzoni, professor at Harvard Medical School. And if you have more questions about PMR, you should check out my PMR guide, all about prednisone and PMR and all the things you need to know about PMR to minimize your disease. So click the link below to get access to that now. Prednisone fails women with giant cell arteritis. That's what a professor at Harvard Medical School taught me this weekend at Harvard in Cambridge, Massachusetts, at an event where we learned all about prednisone and giant cell arteritis and other vasculitis conditions. It was an amazing opportunity, and his presentation reflected many of the things I've believed for a long time about prednisone, but didn't have his context to articulate it well. So he shared results of his studies and other people's, all about GCA, which is giant cell arteritis, but I'm going to call it GCA from now on, and what we can possibly do instead. So these are some myths that rheumatologists might tell themselves, or they might say the patient-specific version to you that he wanted to bust. These are them. There is a golden dose of prednisone for my patient that will control GCA. And he's going to prove these faults throughout the rest of what he says. And his name is John Stone, MD, and he's an MPH as well. He went to Harvard Medical School. He also did a residency at Johns Hopkins, and now he teaches at Harvard Medical School. Like, he's the top author on New England Journal of Medicine and Journal of American Medical Association articles. He's like the expert, okay? And these are his myths he's busting. Steroids have side effects, but I know how to use them for my patients. And this is what he wanted to drive home, is that the safety of a drug, prednisone, relates not only to the adverse effects, what we call side effects, but to efficacy. So what he's really referring to is the balance of risks and benefits. He used big fancy words, but I'm just going to use a scale. So if this is a scale, and you're trying to decide which is worse, right? My disease or the side effects of the drug. And he's saying that the efficacy is your disease, how well the drug is actually working for your disease. And then the side effects, how horrible are the side effects? And so if the drug works perfectly 100% of the time in all the people at any dose, then that's an amazing thing. And it totally tips the balance to who cares how many side effects there are? The drug is always working. Versus the drug has tons of side effects and never works, so we shouldn't use it, right? You get that scale? So we're going to talk about, for GCA, what are the factors that we need to consider? So first we're going to talk about the drug itself. Does it work? Okay. Does prednisone work for people with giant cell arteritis? And they did a giant study, and he was the top author, called GIACTA or GIACTA. G-I, big A-C-T-A. And they found that there was a 5 times greater risk of failure of treatment in women than men taking prednisone. So prednisone does not work in women for some reason. He said that a longer taper led to 50% more prednisone use at 6 months versus 1 year. In this study, they studied whether 6 months of prednisone or a year of prednisone or a different drug would be a better option for giant cell arteritis. And so when they compared 6 months of prednisone to a year of prednisone on whether there was a relapse of giant cell arteritis, whether you got pain, whether you got headaches, whether there was blindness or things like that happening, they found that the people who did a 6-month taper, only 14% of them went into remission. 14 out of 100 people in the study were in remission at 6 months, okay? That means 86% of the people who took 6 months of prednisone had a flare or it didn't work, okay? So like most of the people it did not work for. Then if you do the year, if they were on prednisone for a whole year, they're taking twice as much prednisone, okay? I guess they said 50% more prednisone. Only 18% of the people taking prednisone for a year were in remission. So 82% of the people were not in remission at a year after taking prednisone for giant cell arteritis. Prednisone did not work for most of these people, and it didn't really matter if it was 6 months or a year. It was almost the same, 18%, 14%. Most of the people were not in remission. So he said the duration of prednisone treatment mattered very little, that prednisone fails most patients with GCA, and that prednisone failure is the rule. The exception is when it works. Most of the time, GCA is not treated by prednisone, and it's worst in women. So they want to know, okay, so where is the flare happening? Because if we can find that perfect dose of prednisone and the side effects aren't that bad, then maybe we can keep somebody on that dose forever and they won't be suffering too much other stuff. So they looked to find out what dose was a person taking when they had the flare. So they discovered that 2/3 of people taking prednisone had a flare when taking more than 5 milligrams a day. Okay, remember that number, 5 milligrams a day. 3/4 of the people who did a full year taper, their flare occurred at more than 5 milligrams a day. So most people are flaring at a dose more than 5 milligrams. 68% of those who did the 6-month taper flared, and 48% of those who did a 1-year taper flared. So still almost half and more than 2/3 people flared. And then when they averaged it out to find the median dose of the prednisone flare, the average dose of prednisone per day at flare was 9 milligrams. 9. Okay, this is going to come back when we're talking about the side effects to find out the balance of risks and benefits. So his conclusion was it doesn't matter how long the taper is. It's the dose that matters. Whether you taper to 9 milligrams and they flare, or whether you taper really fast or really slow, it didn't matter. It was getting to whatever that dose was where that person flared. So now that we know most people flare at an average of 9 milligrams, some more than that, some less than that, what about the side effects? How bad are the side effects at 9 milligrams? All right. So he looked at different other studies and he asked, is there a dose that is well tolerated from the standpoint of adverse effects? So is there this golden dose where the side effects are okay? And his conclusion is that all patients on chronic glucocorticoids suffer from the same condition, steroid toxicity. To translate that into English, all patients on prednisone for a long time suffer from the same condition, prednisone side effects that are toxic. Toxicity. All. There's no exceptions here. He's saying, this is the #1 researcher in the world, okay? And he's saying there are no exceptions. And he said that the things that can make it worse are age and gender. So the older you are, the worse the side effects, generally. Most side effects. Some were worse when you're younger, but most of them get worse as you age. And your gender. It's clearly failing women. A lot of the side effects are worse for women. So let's talk about 3 types of side effects and what dose they're happening at. So the first one is infection. We're taking prednisone, an immunosuppressant, and an anti-inflammatory medication. And so how bad really is this immunosuppressant effect of it? So they did a giant study of 200,000 patients who have rheumatoid arthritis, and they looked for one outcome, all right? Whether or not this rheumatoid arthritis patient was hospitalized for an infection. That's it. They looked at Medicare claims data, they looked at Optum claims data to see if they're taking a steroid and whether or not they've been hospitalized for an infection. So there are lots of other infections that don't require hospitalization. So these are like the worst infections, right? Like you don't get hospitalized for, simple infections. You get hospitalized for things that are really, really bad. So they figured out what dose these people were taking. And of those, in the lowest dose of prednisone group, the less than 5 milligram a day group, less than 5, 11% had an infection sometime in 1 year. More than 1 in 10 people who were taking prednisone for rheumatoid arthritis for 1 year had an infection that required hospitalization. And a low dose at that, less than 5 milligrams. Mind blown. So then what if they looked at higher doses? Because less than 5 milligrams is a very small dose. Does it get worse, or is this just because these people have rheumatoid arthritis? Well, when we go to 5 to 10 milligram a day dose, the incidence of infection at 1 year goes to 14.4% of those taking prednisone for a year got a hospitalized infection. Well, what if you're at over 10 milligrams a day? How many people? 17.7% of those taking more than 10 milligrams a day will end up in the hospital for an infection. Ouch. That means almost 1 in 5 people taking prednisone for more than a year for rheumatoid arthritis will end up in the hospital with an infection. Holy cow. All right. So that was infections. What about blood sugar, diabetes, blood glucose? Does prednisone really cause problems? Well, back to that GIACTA study. I actually got to talk to this researcher who published this article a lot, Naomi Patel. She gave another amazing presentation. But the research published by her showed that when you compared the prednisone 6 months, prednisone a year, and then the other treatment for 6 months for a year to each other, or the doses, that the blood glucose was the worst for the patients on prednisone. And the higher the dose, the worse the blood glucose changes. And they were specifically measuring hemoglobin A1C. So that's like a measure of long-term blood glucose changes. So it's real. It happens. The higher the dose, the worse it is. Okay, so we did infection. We did blood glucose. Now, heart disease. Does prednisone really cause heart disease, and why should I care? Let's find out. In a study looking for all types of cardiovascular disease or heart disease, they found that the hazard ratio was 1.7 for those who are currently using glucocorticoids versus those who are not. To translate that into English, you have a 70% greater chance of heart disease compared to someone who's not taking prednisone. And those are things like atrial fibrillation, heart failure, myocardial infarction, which is a heart attack, or peripheral arterial disease, which is like your arteries start not working in your legs, and it's very painful and ugly. So it's a 1.7 hazard ratio. Ugh. All right. What about less than 5 milligrams a day, though? What if we're looking for lower doses? So if we're only looking at less than 5 milligrams a day, the hazard ratio is 1.5, 50% increased risk. All right. What about we're doing a really big dose, greater than 25 milligrams a day? The hazard ratio is now 2.8 times. Yikes. Okay. What about if we're looking at dose over a lifetime? They call this a cumulative glucocorticoid dose. So like if you get huge doses of IV steroids, or you take lots of prednisone by mouth for a long time, it adds up. Like for me, I had to do 60 milligrams many days. And then one other time I had to do basically 1,000 milligram equivalent of prednisone in one day. So my cumulative amount of steroids I've been exposed to is probably close to 2 grams, maybe more. I haven't added up. I should. But it's a lot. And so they're looking at people who've gotten less than half of what I've gotten over a lifetime, less than 960 milligrams. And they said the hazard ratio was 1.2. But what if you've had 7.3 grams? So somebody who's had like 3 to 4 times more than me, the hazard ratio for heart disease is 1.5. So it's bad. Okay, then he showed some tolerability studies by the European League Against Rheumatism. So the doctors in Europe who prescribe and treat prednisone patients for rheumatology conditions. And they decided that 10 milligram a day and above is not well tolerated by any patients. Like nobody should be taking 10 milligram above long-term. It's not tolerated well. Then 6 to 10 milligrams per day is tolerated poorly by many. So most people don't feel well with that and have risks for lots of complications. 5 milligrams or less may be okay in the right patient. So basically 5 milligram or less is the recommended. Anything above that, most people feel awful. But remember, the median dose of a flare of giant cell arteritis was 9 milligrams a day. So 5 milligrams was our cutoff for it being an okay thing. Most people taking prednisone for GCA are in the 10 milligram and above, feeling horrible, and EULAR says not tolerated well by any patient. So we're looking at the benefits and risks. The benefits, it only works for some people at a golden dose of 9 milligrams and above. And the side effects are happening to a lot of people, and they're really bad unless you're below 5 milligrams. So you need 9 milligrams to get it to work, but the side effects are bad. It's super hard to decide what to do. So what can you do if prednisone treatment for giant cell arteritis is failing you as a woman? What can you do? Well, they did a study, and John Stone, the author of the study, was also the presenter of this article. Conflict of interest? No, I don't think so. He just happens to be the expert, and he was telling us all about this. But then I discovered he also wrote this article. And it's where they did a study to submit to the FDA to get FDA approval for an alternative treatment for giant cell arteritis. And it's called tocilizumab or Actemra. And it was shown to be effective. And remember that 14 and 18% failure rate, like only 14% were successful and 18% were successful at 6 months and a year. So let's compare that to tocilizumab, the Actemra. A year, 56% of those treated weekly with Actemra, and 53% of those every other week were in sustained remission at a year. So if it were me and I was feeling these horrific side effects, not well tolerated, and prednisone's failing me, I'm having flares, I would get on Actemra for sure. I would get over any fears of needles, fears of side effects of Actemra, because the doctors over and over, the world-renowned experts, rheumatologists, over and over said a variation of this, that prednisone is the most toxic drug that they prescribe. It is the worst one to be on. It's not working, and it causes the most horrible side effects. So anything else is a good option. Literally, I would try any other option if it were me. I would try Actemra. I would do whatever I can to get my insurance to approve Actemra. I would work with my doctors to get the Actemra. That's what I would do if it were me with giant cell arteritis. So Dr. Stone had some conclusions that I'd love to share with you. To repeat, steroids fail the majority of patients with GCA. There is no golden dose of prednisone. And the search for a golden dose places patients with GCA at risk. And steroid-sparing treatment should be started simultaneously with steroids. Try saying that 10 times fast. All those S's. But essentially, if you're diagnosed with GCA, your doctor should give you some prednisone and a different medication, whether it's Actemra or the new treatments that are being researched, because there are other ones that I haven't mentioned yet. But you want to get that treatment as soon as possible, because it didn't matter how long the prednisone taper was. People failed. It didn't work. Not people failed. The drug failed people. Prednisone failed women. And so steroids should be discontinued as soon as possible, whenever possible. That's his biggest takeaway, is that there's no reason to be on a lifelong treatment with GCA if you can get on one of these other medications. We want to get on the lowest amount of steroids so that we can minimize our risk for heart disease, for blood sugar issues, for infections, and all the many other side effects. And finally, treatment is more likely to fail women than men. So if you're a woman, you're wondering any other things you could do to be steroid sparing to minimize your risk for side effects, but things that you can actually do, and you don't have to wait for your doctor to prescribe. I have a prednisone checklist, and it includes the top side effects of prednisone, some of which I've gone through today, and what you can actually do to minimize your risk for complications. I go through each of those, and they're evidence-based. So published articles have shown that you should do this and this and this and this and this. And you can just check it off. Oh, I've done this, I've done this. And then you'll know you're doing everything in your hands to keep yourself safe and minimally affected by these side effects while taking prednisone. What does it feel like to have polymyalgia rheumatica, or PMR? I've been asked to describe it by many, and I've personally never had PMR, but I have the story of a prednisone warrior named John, who personally was diagnosed with PMR and wanted to share his story. He has some tips at the end, so make sure you're there for those, and I'll have a few comments. So without further ado, I'm going to share prednisone warrior John's story about being diagnosed with polymyalgia rheumatica. He says, 3 years ago, I was 75 years old. March 22nd, 2021, the day after I received my first COVID shot. I could not get out of bed by myself. Trouble with all basic functions. Mostly it was my shoulder and hands, but a lot of my body had trouble. Nobody could help or support me. Only my wife was a hero, helping out of bed, sometimes 3 to 5 times, mowing the lawn, all things needing to be done. It was COVID time. My doctor didn't have a clue and did not want to see me and tried to give me opioids, which did nothing but made me feel rotten. 4 months, summer, went by, and on August 2nd, I went to the hospital. I thought it would fix itself, but no. I was not able to sleep much. The emergency doctor was not very accommodating either, as I've always looked young for my age. I insisted I could not function at all. After a month, I had the COVID vaccine and I diagnosed myself with PMR because of the extreme shoulder pain, a telltale sign for 95% of those with PMR. I read then and believe today, but very few were aware of this, and my doctor did not know or believe it. I was in the emergency for 9 hours, blood tests, and I insisted there was something very wrong. Finally, the doctor said, "I believe you have PMR." I had not told him when I came in that is what I thought. Not trying to do his job. CRP reading of 61, 1 being the normal, and an elevated ESR reading. I said, "I believe you are right," as that is what I had concluded myself. He had a prednisone prescription ready. The next day, I was 60% better, tapering off, etc. But since that time, I am still dealing with arthritis, improving a little each day and learning more. They say it can take 1 to 5 years to recover fully if you do. I was on a regimen of prednisone twice, also 6 months after the first, and still learning more. I read your online advice in the first year. Thanks a million. I know more now, and that prednisone is only a temporary aid. I am 3 years older now, at 78 years old, and doing okay, but still studying and learning ways to improve. A little history. I learned that PMR is still mysterious, and experts only know the cause is believed to be genetics plus a trigger. I have some genetics, family arthritis, and the COVID vaccine was the trigger for sure, as I violently reacted the next day. I feel at about 85 to 90% now. I was very active in my life. Hobby, farmer, sailor, cycled across Canada, 7,600 kilometers, at age 60, and much more. I believe one has to be very positive in the situation and look hard for answers. My hands have had trouble too, but improving, to the extent that I am soon hoping to get my bicycle out. I have been using a Free Spirit elliptical trainer for the last 2 years, which is low impact machine that is building back my strength. A good option. Yes, my journey has not been easy, but optimism is helping me through. My wife and I have 4 children in early 50s. We've been married for 55 years, 9 grandchildren, 2 married, and others on that road. Most health issues, I believe, come down to some basic factors for improvement. These are his tips. Heredity, food, exercise, being positive, lifestyle, enjoyment, happiness, and more. Telling my story that optimism and effort are a big part of getting well. Also, prednisone can give relief, but certainly is not the solution. For all those who may benefit from my journey and testimony, wishing you well, Megan, as your important role as a health advisor. Thank you, Jean, for sharing your story. I appreciate how PMR is a really tough condition because it affects people who are usually otherwise healthy, and then suddenly, out of nowhere, usually, they suddenly have horrible shoulder, hip, wrist pain. And that's exactly what his story shows. If you would like to hear the tips that he referred to that were thanks a million, then you should download my free Prednisone Checklist. It's available at the link below, and it has my best tips for how to stay well, even while taking prednisone. Click the link below to download it now. Can Actemra help with polymyalgia rheumatica to help get off prednisone so that you can minimize your side effects of prednisone? That is a great question I've been asked multiple times. So I thought I would share the story of prednisone warrior Mike. Mike shared his story by typing it up for me. And so what I'm going to do is read his story that he typed. And at the end, I will have a few comments about his experience and the tips he shared to help you on your journey while taking prednisone and suffering side effects. So without further ado, here is the story by Mike. Mike says, I have had a combination of autoimmune problems for 35 years. PMR, which stands for Polymyalgia rheumatica, was added to my problem list about 15 years ago. When PMR was diagnosed, I was started on a 40 milligram dose of prednisone. I was never able to decrease my prednisone dose much lower than 10 milligrams for the next 12 years. That seems strange to me because I was very adept with tapering off high doses of prednisone for my other autoimmune conditions. Several alternatives to prednisone were tried, Methotrexate and leflunomide probably helped the most. However, I stopped methotrexate because I'm feeling sick and my liver enzymes were elevated. Leflunomide was stopped by my doctors because of infections. Actemra was suggested by my rheumatologist as a last resort, but at the time, it wasn't FDA approved for PMR or any other diagnosis I have. My rheumatologist asked if I would be willing to try Actemra if he could get it approved for me. I was reluctant to try Actemra because I had never heard of it before. My rheumatologist suggested it. My rheumatologist submitted a request and got it approved. I actually wanted to try a TNF inhibitor. TNF inhibitor stands for tumor necrosis factor alpha, because I was diagnosed with inflammatory arthritis with uveitis at the age of 32. PMR was tacked on when I was 52 years old, as I recall. I felt like I had nothing to lose by trying Actemra. I thought Actemra would fail, but then I could try a TNF inhibitor. My rheumatologist wanted me to try Actemra first. I started Actemra injections every 2 weeks with my very first injection on January 1st, 2019. It seemed like a good way to start a new year, but I wasn't very optimistic that Actemra would work. 7 months after starting Actemra, I was able to taper off prednisone. Actemra seemed like it worked for my PMR symptoms, but I had a flare of uveitis. So that's an eye issue. And was started on 60 milligrams of prednisone again. Many things happened after that. Actemra was stopped and Humira was tried to get the flare of uveitis under control. I started having PMR symptoms when I tried to taper off prednisone again. It seemed like Humira wasn't working for PMR. My rheumatologist gave me a choice of Actemra or Humira, but not both. I chose Actemra and tapered off prednisone a second time. I haven't been able to stop Actemra, and I currently do monthly infusions. My rheumatologist thinks I'm better off being on Actemra. Wow, what a story. That is a very long time to have to suffer with PMR and autoimmune conditions and taking prednisone and dealing with the side effects. What a story he shares. And I really appreciate how his rheumatologist didn't stop giving him options and helping him find solutions, because as you can hear from his story, he's been through nearly everything. And I'm really glad to hear his doctor prioritizing getting off prednisone above other things. A lot of people are confused about whether prednisone is safer than Actemra or Humira or methotrexate or leflunomide or Cellcept or Imuran. And I agree with this rheumatologist and the guideline created by rheumatologists for the treatment of conditions that prednisone is probably the most harmful of all of those drugs. Even though the side effect profiles of the other ones seem really scary, and there are a few rare side effects that can happen that are really bad for some of those, the overall damage that prednisone can cause long-term is horrible. And so I'm really glad to hear that his case, he was able to get off prednisone not once, but twice because of Actemra. And to me, that is a win. Actemra is, I agree with the doctor, the lesser of all of the evils. And it's fantastic that he was actually able to get off prednisone by using Actemra. The goal of Actemra is really actually to just get on the lowest dose possible of prednisone. Being able to actually taper off prednisone completely is a secondary goal that I'm so glad he was able to achieve twice. So if this is you taking prednisone for PMR and you're wondering, should I do Actemra? Here's your answer. Yes, getting off prednisone is the best thing you can possibly do. And if you can't get off prednisone, getting to the lowest effective dose and staying on that is a good idea. If you can stay on 5 milligrams or below, that's the best option. And definitely work this out with your doctor. This is not medical advice. This is simply somebody's story and my general advice for people taking prednisone for PMR. Do you have a ravenous appetite while on prednisone? Well, this prednisone warrior had a ravenous appetite and wanted to know what she could do about it. So here are the ideas I can share of how to deal with a ravenous appetite from prednisone. Here are her words. Her name's Sandra Elim 5656 on YouTube. I'm on prednisone for PMR. Is there anything I can do to help with my ravenous appetite that you know of? My rheumatologist says, willpower. I seem to have no willpower. Also, don't sleep well. I know you can just give me your ideas, but that's what I'd like. Thank you in advance. Well, Sandra and anyone else with PMR or taking prednisone and having a ravenous appetite, let me share you the reason why and then what you can do about it. We're all so grateful for prednisone for what it's doing for our bodies. It saved my life from bleeding to death, and people with PMR absolutely are grateful that it allows you to lift your arms, to walk, to get out of bed, to do so many things that you aren't able to do when PMR is fully flaring. And prednisone is this miracle because it's mimicking our body's natural hormone called cortisol. Cortisol is Mother Nature's hormone to help us survive disasters. And the way she's doing that is how it's causing this ravenous appetite. So the disasters I'm talking about include a famine, a war, being chased by a tiger. Those situations are theoretically temporary, and there's a way to resolve it in the near-ish future. Not like taking prednisone and maybe you're going to have to take it the rest of your life or for years at a time if you have PMR. And what it's doing is it's stealing from your reserves, your savings account that you've been building up over your entire life, and using that rainy day fund to get you through this moment. Because if you're in a famine, war, or being chased by a cheetah, if you don't deal with that immediate threat, there is no you left to save, right? So Mother Nature doesn't care that it's going to cause osteoporosis. Mother Nature doesn't care that it's giving you diabetes. Mother Nature doesn't care that you're going to go blind from a glaucoma. None of those matter if you're not going to live long enough to get those complications, right? So it's basically cutting all losses. Let's just do what we've got to do to survive. One of the things it's doing is activating the parts of your body that are going to give you the ability to get away, to survive this threat, to run away from the cheetah, run away from the roar, or run to the next source of food in a famine. And it's doing that by activating your stores of glucose, sugar, glycogen in your liver, your muscles. It's activating all of those things. And then it's turning off your insulin sensitivity. It wants you to use that blood sugar through running away, through using your muscles, instead of through the other ways that normally that blood sugar would be used that you need insulin for. It's trying to give you this boost, like it's like a jet pack to like get you going really fast to get away, right? And so it's increasing your blood glucose, your blood sugars. It's turning down your ability to use insulin. And then it's messing with what's called adipokines. These are the hormone messengers that tell your body what to do with metabolism things, whether to use fat or store fat, where to store the fat, things like that. It's changing those, and it's changing your metabolism signals of I'm full or I'm hungry. Things like leptin, ghrelin, GLP-1, right? All of these signals tell your body eat, or you're full, you're okay, you don't need to eat anymore. They're all being dysregulated. You're basically being told to put the gas on full blast and lifting up the brake. There's nothing telling you to stop eating. Those signalers are being suppressed, and the hunger is full on. Why would Mother Nature do this? Well, because if you're in that famine and you're running to get the next source of food, it wants you to just inhale that source of food and get to the next one. So like you're running through the forest and you see some berries, you eat them as fast as you can and you just keep running, right? Get to the next source of food, get to the next source of food. It wants you to just consume whatever's available easily. It's not wanting you to spend time like tracking an animal and killing it and roasting it and putting it in a stew. That takes too much time. It doesn't want you to spend time planting seeds, tending plants, and harvesting 6 months later. It just wants you to get through this moment. So you are being told by this drug in the form of its signals through cortisol to forget long-term, to only see this moment. And the full-on gas is for things that aren't good for you. It's making you preferentially choose high sugar, high salt, high fat. Basically, Oreos, right? Oreos and chips. Things that we absolutely know for a fact in our brains aren't good for us, but prednisone thinks they're the best. And they're not. And so you're thinking, great, now what do I do with this? Thanks for letting me know that it's all stacked against me, right? Well, there are several keys in this that we can turn. There are several levers we can utilize. Because one of the ways that prednisone is causing the high blood sugar and the poor use of insulin is because it's telling your body to pee out chromium. What is chromium? Chromium is a metal mineral that you normally have just enough of in a really tiny bit, but you have enough to use with insulin to allow the insulin to open the door to use the glucose. If you have this ongoing high glucose, messed up insulin, that leads to hunger cravings. That leads eventually to diabetes, heart disease, blindness, kidney problems, neuropathy, and all those complications. So it all starts with the fact that prednisone is stealing chromium, making it impossible for you to use your insulin right. Some researchers in Israel thought this was so important, they did a study and they gave people chromium picolinate, it's a special kind of chromium, 200 microgram doses. That's a super tiny amount, but it was enough that they said in the headline of their article to reverse diabetes caused by steroids like prednisone, steroid-induced diabetes. It was able to reverse that. So chromium picolinate is vital to counteract this ravenous appetite. It is the missing ingredient in keeping your appetite more regular. So you've got to be supplementing with chromium picolinate because you're legitimately losing it while taking prednisone. So you need to give chromium picolinate back because before those researchers gave these people chromium picolinate, they had diabetes caused by prednisone because there was a loss of chromium. When they replenished the chromium, they were able to reverse that diabetes. So you need to take chromium picolinate if you're having appetite issues. If you're having any weird metabolism issues, start with chromium picolinate and it will help you to not feel so horrible having this ravenous appetite. And like your rheumatologist, let's just talk about medical gaslighting here. Your rheumatologist is telling you that it's willpower, except your rheumatologist is giving you a drug that is literally removing your willpower. Like it is turning on hormones that tell you to be hungry and turning off hormones that tell you you're full. Your doctor's actually causing this problem, right? Like they're giving you the drug's causing these complications. So it is not willpower. But what can we do about willpower, right? Like if we really have very little of it, what can we do? So one thing is simply include only things that are going to help you in your house. Do not allow anything into your house that you could go shove your face with. Oreos, chips, ice cream, whatever. Get them out of your house. Like if you're taking prednisone, those are just things you can't deal with right now. Like your body cannot handle those temptations. This drug that is saving your life in my case, or in somebody with PMR, literally allowing you to function, the price you're paying is you've got to cut things out of your life that aren't going to match. And that includes foods that can give you no nutrient benefit and worsen this cycle. So just cut all refined, ultra processed foods out of your life. Just don't have them in your house. Okay. That's step one. Step two, start with protein and vegetables. If every single meal has a form of protein and a form of vegetables, and that's the only change you make after watching this, is you eat protein and vegetables and then you eat other things, you'll probably have a less ravenous appetite. If that's all you do, like follow any diet you want. I don't care if it's Mediterranean, keto, VB6, the South Beach diet. I don't care which one you follow. They all do this exact same thing. Protein, vegetables, and some other complications of other things. If that's all you do, it is going to be powerful in controlling your appetite. Some people find that eating a keto diet will help with that ravenous appetite as well, because you're not getting blood sugar fluctuations like you would before. Now let's talk about and don't sleep well part of your question. So you said you don't sleep well. So we already talked about how prednisone is stealing chromium. I can also mention when we go to osteoporosis, this permanent irreversible side effect, it's because, as the doctors who prescribe prednisone the most say, it's because it's stealing calcium and vitamin D. Well, what's causing this not sleep well issue? Well, having blood sugar issues alone is going to affect the quality of your sleep. But the number one tweeted side effect of prednisone is insomnia. People who take prednisone are experiencing insomnia so much, and it's so typical that it's the number one thing somebody will tweet about when they take prednisone. So what can you do about it? Well, the reason it's causing you to not sleep well is because prednisone is affecting your melatonin. Normally, your body makes cortisol in this beautiful rhythm, and prednisone is the cortisol replacement, right? So normally you have this sunrise of cortisol. When the sun comes up, the cortisol comes up, and then it goes down throughout the day. And then at bedtime, it's pretty much gone. And at that same moment, the melatonin it starts out high and then goes down low. So one's high and then low, and the other one's high and then low. And they're just mimicking each other. And they're in a yin and yang with each other. When cortisol is like the sun, it rises and then it sets. Melatonin's like the moon that rises and it sets. And one dose of prednisone or dexamethasone in one study of healthy young males was enough to completely deregulate this system, which is called the circadian rhythm. One dose was enough to completely deregulate that. And so what do you need to do? Because you're throwing your cortisol so high, it's off the charts, you need to give back melatonin so that you can sleep well. But you can't just give back melatonin alone. You need to give back the building blocks from melatonin, like magnesium. Magnesium is vital for that, but it's also helpful for blood sugar support. It's also helpful for your bones. It's also helpful to keep your mood stable. So you need to be giving back magnesium as well. So now I've mentioned a whole bunch of things. We need to talk about chromium, calcium, vitamin D, magnesium, melatonin. And if you go out and buy all of those things, you're going to spend a fortune on supplements, and you're going to probably end up swallowing like 16 pills a day. No one wants to do that. And I certainly didn't want to do that when I was taking prednisone, when I realized that I needed all of these things to counteract all the side effects. So I went out and made it. I invented Nutrinized Zone, and it has those nutrients, a total of 17 high-quality, evidence-based nutrients that are going to support you in your journey taking prednisone. So you can just go to Nutrinized.com, and you can get morning and a bedtime bottle. They come as a twin pack like this, and it's a month supply, and it's all you need while taking prednisone. You don't need anything else. You just take 2 in the morning and 2 at bedtime. The 2 in the morning you take with your morning prednisone dose, and you take the 2 at bedtime to help you sleep well. And this is going to help support your appetite, help support your bones, and it's all in one. You don't have to go and figure out the dose or see if that manufacturer is any good. I only settled for the very best manufacturer and ingredients in this. I've had it tested by third-party labs. And if you take it and you're like, that doesn't work for me, I'll refund you for any reason. Any reason. Just tell me you don't like it and I'll send you your money back. So there's literally no risk to try it. See if this helps you with your ravenous appetite, helps you sleep at night. Go ahead, go to Nutrinized.com or on Amazon and get the support you need while taking prednisone.
Have you ever done something on a daily basis and just had the typical people you always saw? Just if you go to the store, you always see these certain people, or if you go to work, you always see these certain people. Well, one day, the person I used to see on my bike rides was no longer there. He was always running, always going on these long runs, and then suddenly he wasn't there one day, and I didn't know why. And then I found out it was because he had PMR. So this is my friend. He has PMR.
Hi there.
He was suffering. He had to take prednisone, high doses, to get his PMR under control, so he wasn't in so much pain. And so what was that like, just when you first had to be diagnosed and being in pain?
PMR was terrible. I could barely walk, let alone run. In fact, I couldn't get out of bed by myself. It was so bad.
Wow. Like, that made prednisone worth it. That's my thing, is I always want people to only take prednisone if it's worth it. So it was worth it for him, but there's so many side effects if you're going to especially be on it so many years that many people are with PMR. So what were you worried about when you were prescribed prednisone?
Well, like everyone, I've heard about the side effects of prednisone, and I thought, oh, I'm going to get a big moon face. I'm going to gain a lot of weight. I won't be able to sleep at night. Things like that. And that's what I'd heard.
So he approached me and he said, hey, I have to take prednisone. Is there anything you can do to help me? And I said, yes, actually, I invented this supplement called Neutronized Zone. So what has been your experience taking Neutronized Zone?
The Neutronized Zone has really helped a lot. Of course, I've been on prednisone coming up on 2 years now, and I'm down currently to 4 milligrams. And I've always split my dose, and I attribute my success in sleeping at night to the Neutronized. Plus, when I've had my labs done, I've never had an abnormal reading come back, and I think that has a lot to do with the Neutronized also.
Awesome. So sleeping better and normal labs. So what about your bones? Have you had any problems with your bones?
Not that I know of. Nothing shows up in the tests, and I haven't had any problems. I'm back running. I still run 50 to 60 miles a week. No problems at all.
50 to 60 miles a week while on prednisone. Isn't that amazing? This guy, he is a super athlete, even though he has to take prednisone, even though he has PMR. And so if you want to feel better like he does, then you need to get Neutronized Zone, and it'll help you to feel like yourself again, to get back to doing what you used to do, just like he did. Any last words for us?
No, fellow PMR sufferers and prednisone users, hang in there. It all works out if you just keep at it.
Yes, and take he's currently doing the dead slow taper. That's his advice for how to finally get off the prednisone, because those side effects of tapering.
Yeah, but you can see my face is back to normal. I've lost all but 3 of the pounds that I originally gained. So if you just hang in there and keep tapering slowly, it works.
Wonderful. Well, thank you so much for sharing how it really feels to be on prednisone for PMR and take Neutronize along with it. Signing off is Dr. Megan, your prednisone pharmacist. What just came in the mail? And at Amazon. So I discovered that there is one condition that uses prednisone more than any other, and that prednisone is the only treatment that works for it. And it is polymyalgia rheumatica. And so I decided I should probably learn all about this condition called PMR. And then its sister condition, giant cell arteritis. There's my baby. I literally never heard of these in pharmacy school ever. Like they didn't teach about this condition at all. And so, and it's also not FDA approved for PMR. Prednisone is not FDA approved for PMR. And so I had no idea that this condition existed, that it was a reason people take prednisone. Like how would I know? Nobody taught me about it in school, and it's not FDA approved. But the people who have PMR have to take prednisone for higher doses and for longer periods of time than any other condition that I'm aware of, and that there's really no other option. As far as I know, pretty much every other condition out there, there might be an alternative treatment where it might be surgery. It might be like a kidney transplant. It might be methotrexate or hydroxychloroquine or like an injectable or something. Like there's usually some other option for most other conditions that people take prednisone for. But as far as I'm aware, there is nothing else when it comes to PMR. So I am excited to learn all about it. And for those of you who have PMR, let me know below what recommendations you have for good resources. I went on Amazon and this was the top ranking book, but if there are other resources that you know of that I should learn more about PMR with, I did the Pharmacist CE continuing education about it. And so if there's more, I really want to know. I really want to understand this so that I can help you better too. So if you have any recommendations about other conditions that I haven't covered when it comes to taking prednisone for a condition, please let me know if you have a condition that I need to cover, and that what great resources you have for me to learn about it so that I can then create a summary for other people of prednisone and PMR, or prednisone and polymyositis, or prednisone and nephrotic syndrome. Whatever that is, let me know and send me a link for a good book or a good podcast or a good YouTube or something so that I can watch it, read it, listen to it, and understand it better, and then shrink that down, take that science, make it understandable so that you can know how prednisone is really helping you for your condition.
Polymyalgia rheumatica is a condition with bilateral joint pain where the shoulders can be incredibly disabling and painful. It's a horrible condition, and there's only one drug that really helps, called prednisone. Hi, I'm Dr. Megan, and I'm the Prednisone Pharmacist. I'm here to help explain polymyalgia, the treatments, the diagnosis, and what you can do so that it doesn't feel so awful for you. So what in the world is polymyalgia rheumatica? Well, I've read this book and the guidelines written by the American College of Rheumatology and the European League Against Rheumatism. There are 7 hallmark symptoms of PMR to make sure that it's not something else, to make sure it's not rheumatoid arthritis or another disease. They have 7 things that they think are unique to PMR when combined together, okay? So the first thing in this book on the 7 hallmarks is over the age of 50. If you're over the age of 50, then it's more likely to be PMR than something else. If you're under 50, then it might be another condition and they need to rule it out. PMR is a diagnosis of exclusion. They have to make sure that it's not one of the many other things that look kind of like it. And then number 2 is that symptoms last 2 weeks or more. So these symptoms are horrible and they make it so people can't function very well. Number 3, that there must be aching or swelling or pain on both sides. So both shoulders or both hips, the pelvic girdle. And it has to last 2 weeks or longer. And so this swelling, this pain, this inflammation makes it so that when a person wakes up in the morning, there's incredible pain. You might just, oh, it hurts. Not be able to pull yourself out of bed because the shoulders aren't working. You might not be able to drink, to use a cup, to lift up to your mouth, to use, a spoon or a fork. If you're a woman, you might not be able to put your shoulders backwards in order to latch your bra. Things like that are really hard for people with PMR because the shoulder is in such incredible inflammation and pain. Number 4 is that this morning stiffness must last 45 minutes or longer. And so it's not just, oh, it hurts, and then you're able to get out of bed and function. It's nearly an hour of disabling pain. And like I said, PMR is a diagnosis of exclusion. So they're going to do a lot of blood tests to make sure it's not something else. One of those blood tests is number 5, elevated ESR, They want to make sure that your blood tests are showing high inflammation. So ESR stands for erythrocyte sedimentation rate. They want to make sure that that number is high because that means there is inflammation somewhere, probably your shoulder area, causing this number to go high. And then number 6 is an elevated CRP or C-reactive protein. It's another blood test showing inflammation. And when both of those are both showing high, there's a lot of inflammation going on somewhere. So number 7 is that when prednisone is taken, this is an anti-inflammatory drug. With all that inflammation, that there's a rapid response to the prednisone. For some people, they'll say within 2 hours, I went from feeling like an old man to, oh my goodness, I can raise my own arm, I can get dressed, I can put my own clothes on, I can eat, I can play tennis, I can do the things that I couldn't do before. And it's rapid. Some people it's not 2 hours, some people it's 2 days, but there is a definite response to prednisone. And a noticeable lack of response to other medications like ibuprofen or Tylenol, Motrin, Voltaren, all these non-steroidal anti-inflammatories, don't touch it. They seem to have no effect on that kind of inflammation. Only the prednisone and other steroids seem to help. And prednisone seems to be the most widely used medication for PMR. If you're not in the United States, it might be prednisone's sister drug, prednisolone, with a little OL in the middle. It's possible you could use hydrocortisone or dexamethasone, but those are much less widely used. And so what kind of a dose of prednisone would a person with PMR get? Well, this is prednisone 20 milligrams. This is on the higher end, and 10 milligrams and below, definitely 7.5 milligrams and below is considered low. And the dose that is often given for PMR of prednisone is somewhere between 12.5 and 25 milligrams. So it's in the mid to higher range of doses of prednisone. And what they want to see is if they give you this much of the medication, are you responding rapidly? And if you are, then that's a sign that, okay, this is PMR, let's treat it. But if you do respond, that means you're going to be on prednisone for a long time. Most people who take prednisone are taking it for other conditions, such as allergies or asthma, and they might need it for a week, 5 days, maybe 3 weeks. But for people with PMR, it might be 6 months, a year, or even 3 years of treatment with prednisone. The goal of treatment is to help you function, is to help you be able to get out of bed in the morning and do your normal life. And finding the best dose for you is the trickiest part of the PMR treatment, because we want to find a dose that is going to keep that inflammation at bay and allow you to move, but we also want to minimize your exposure to the drug as much as possible because there are so many side effects. So it's a really tricky dance you're going to be playing for the next while, finding the lowest effective dose that you can take. And so it's going to be somewhere between 12.5 and 25 milligrams. Often they will start at 25 and then slowly taper. And then it's usually somewhere below 12.5, around 10 milligrams, where people with PMR really struggle to taper any further. They'll tell me that they got to 10 and then it all flared up and they had to go back up again. And so the tapering is really tricky. There's a really great website I can show you that has different tapering strategies of ways you can taper off. I have a printable taper chart, but essentially you want to get down to below 15 milligrams and then go really slowly after that point, whether that's 1 milligram a month or a half milligram a month. At that point, it's a really tough situation. And often people work with their doctor to get different strengths of prednisone. They start out maybe with a 20 milligram, but then they'll get a 10 milligram, a 5 milligram, and a 1 milligram so that they can work out what that exact dose is themselves. And not everyone is given that opportunity, but often doctors will say, okay, we got you to this point, and now I'm going to let you listen to your body and find a way to taper from here. And so you might be on 10 milligrams for a week, and then the next week you take 9 milligrams for Monday, Wednesday, and Friday. And then the following week you do it 5 days, and you just slowly go down by 1 milligram, maybe even slower than that. Maybe only one day out of the week you're down 1 milligram. It really depends. And so check out that website, see what tapering options they have. And now, what side effects would you be looking for? Which side effects should you be afraid of with prednisone? Well, I personally had to take prednisone for a different autoimmune condition, and I had to take it for 8 to 9 months, and it was miserable. I gained weight. I got a big round moon face. I lost muscle mass in my arms and my legs. I lost bone mass. And so I was increasing my risk for osteoporosis and fractures. Another sign of that is losing height by the bones in your spine compressing on each other. Osteoporosis. I had mood swings. I felt cranky around my family. I had insomnia. I had little shaky feelings. I had so many miserable side effects. And so it's really hard to want to continue taking the prednisone because it feels so awful. But the PMR feels worse, right? And so finding that balance of, okay, my PMR is under control and I'm taking the lowest effective dose that's keeping me in balance. It's really tricky. So are there any alternatives you could take to prednisone? We've already mentioned you don't want to try ibuprofen or Tylenol. Those don't work. Are there any prescription treatments? Well, I mean, other steroids could help, but is there anything else? Well, recently, the FDA has approved a few biologic treatments for people who have the diagnosis of PMR. And now these are not perfect. These are not slam dunk. If they were, no one would take prednisone ever again. And they are also very expensive. So these are called IL-6 or interleukin-6 inhibitors. And the first one approved was Actemra. And it was originally approved for rheumatoid arthritis. And then the second one that was recently approved is Kevzara, which is also sarilumab. And then the Actemra is tocilizumab. And so these monoclonal antibodies, they're injectable and they block a signal in your body that is responsible for inflammation. That's the IL-6. The problem is they can increase risk for infections. Prednisone also increases your risk for infections. And so they come with their own list of side effects. When they compared Kevzara to placebo, so like no treatment versus Kevzara, and they wanted to see who was in remission. And Kevzara got 28% of people into remission, and prednisone got 10% of people into remission. So 3 times more people, but it's not like it was 100%. It was only 28%. And it just doesn't work that well, and it does cause more side effects. Like people complained of tons of side effects with it too. And what about Actemra? So Actemra, like I said, was the first one approved. And when they compared prednisone to Actemra or tocilizumab, they found that 63% of people who take Actemra got to be in steroid-free remission versus 12% of people who were taking prednisone got into remission from PMR. So it does seem to work better than Kevzara, but still, 63% is not 100%. And it does come with its own side effects. So there's no perfect answer when it comes to these alternative medications for PMR. Which ones should we definitely not use? The doctors said definitely do not try other medications instantly. They want you to start out with the prednisone. So if prednisone is terrible and it doesn't seem to be working out well, after a while you could add on something called methotrexate and it might help. But again, it's not that effective. Because prednisone is so harmful, they want people to be doing exercise to help counteract the side effects. And so if you possibly can, do muscle strengthening and bone strengthening exercise as well on prednisone. There's also a lot of other things you can do to counteract the side effects of prednisone. And I include those in my prednisone checklist. I'm trying to help you find the right balance between the benefits of it helping you function and getting the side effects to be as minimal as possible. So I created a prednisone checklist, and it goes through the things you need to follow up with, whether it's for your bones or your eyes or your muscles or your heart, to make sure that the benefits are outweighing the risks for you. And then I also go through the top 7 mistakes that people often make when taking prednisone. I don't want you to have to make those mistakes. So download my Prednisone checklist now, and then you won't have to make those mistakes, and you'll know exactly what you need to follow up while you're taking medications like prednisone. Signing off as Dr. Megan, your prednisone pharmacist.